Great. I think we're ready to start. Thank you all for being here so punctually. My name is Bria Lehman. I'm a lecturer at the Statistical Science department here at UCL. And as you can tell by my very jazzy jacket, I'm going to be your host for today. So today we've got a very exciting lineup of talks for the Statistical Methods for Health Equity Symposium. Here's the agenda for today. There's lots of QR codes in this set of intro talks. So if you want to get your phones out, get the agenda up for you, then now's the time to do so. So we'll start off with me giving a bit of an intro about today's series of talks. Then we'll follow by our keynote talk from Professor Bhramar Mukherjee from University of Michigan. Lots of breaks dotted throughout the day. So follow that up for a break, then a set of 4 excellent research talks from researchers across UCL. Then we'll have a break for lunch, followed by a workshop session run by Antonella and Mai Perini from the Alan Turing Institute. Yet another coffee break. You'll be sufficiently caffeinated throughout the day. Then we'll finish off with a panel session on translating data science research into equitable health policy. And if you can stay around after the set of talks, we also have some networking drinks at the end of the day. It's great to see as many of you as possible. A bit of housekeeping. Fire exits are here and here. I believe you can also exit around the back. I'm sure that won't be necessary. We're following the AI Fringe Code of Conduct. I'll say a bit more about the AI Fringe in a second. But in short, be considerate, respectful, and collaborative. We all come from kind of different backgrounds, different fields as well. And so we'll come from different I guess, points of view. So just be aware of that as we're having conversations and discussions, which I'm hoping will be very fruitful throughout the day. As you will have heard, this workshop is being recorded and we'll make the recording available towards the end of the week. We'll be using slido.com for audience Q&A, and I'll flash up the Slido QR codes and kind of numbers. For those in the room, we do have some mics here, so we can do those live if need be, but if you prefer to ask anonymously, or if you just want people to kind of upvote your question and feel good about yourself, then Slido is the way to go. If you enjoy live tweeting, or I don't know what people are posting on X now, but you can use the hashtag DSXHE, which is our Dishy Data Science for Health Equity hashtag. Great. So as you saw on the welcome slide, we have a number of hosts and sponsors for this event. So this is part of the AI Fringe series of events, which is a satellite to the Government AI Safety Summit, which took place last week, predominantly based in London, but also with events throughout the UK. And the Fringe is hoping to capture the energy of the interest in AI safety to help chart a path towards a more collaborative, safe, and inclusive AI ecosystem. And I'm sure it's not a stretch to see how we can think about using statistical methods to advance health equity, but it's very much in this theme of events. It also lets me use my favorite statistics versus AI cartoon. As a statistician, I always get a bit frustrated when people refer to things as AI. So this I think is a great cartoon. And I think I'm going to put in a proposal next year for a linear regression safety summit, which we can do a fun fringe event around that. This is also part of the Economic and Social Research Council Festival of Social Science, as you'll see from the banners. This is an annual celebration of research and knowledge about humans and society, and this is the 21st edition of the Festival of Social Science. Over 200 events delivered by 42 universities across the UK, including UCL, obviously. The theme for 2023 is lifelong well-being, and we have the Festival of Social Science to thank for the biscuits, pastries, and coffee today. So if you know anyone from the festival, then give them a big thank you. Last but not least, I want to say a few words about data science for health equity. the data science for health equity is a community of interest, a community of practice. And the motivation behind the community is that, well, as we're all aware, digital technologies are being used in all facets of healthcare, from general practice, from operating theatres to public health and beyond. But the question we're hoping to answer is, how do we ensure that the latest data-driven innovations in digital technologies benefit the health of everyone? So DISHI, which short for Data Science for Health Equity, is a global community of experts and enthusiasts working at the intersection of data science and health inequalities. We're cross-sector and cross-discipline and open to anyone who has an interest in data science, health equity, ethics, and everything in between. Amongst our members, we count many health and care professionals, plenty of academics, policymakers, funders, folks in the private sector, media professionals, and so on. Lots of ways to get involved. I've put yet another QR code here, which I'm hoping is the one that points to the right website. It's confused. You can't really tell like if a QR code is right on the screen, right? But there we have a short URL there if you'd like to look at our website. You can also, if you scroll down to the bottom of the homepage, you can subscribe to our monthly newsletter. You can also follow us on Twitter. If you want to get really involved, then we have a Slack workspace, which I forgot to include the QR code for that. Shame. So this symposium is on statistical methods for health equity, which is a subset of the data science for health equity community. And the rationale behind this this theme within the community is that, well, we believe that data can shed light on the complex factors underlying health inequalities through, sophisticated statistical modeling. But there's also a danger of entrenching disparities through algorithms trained on biased data sets. So the aim of this theme is to improve our understanding of inequalities and reduce disparities through the development of better statistical and machine learning methods. We run a number of kind of regular activities, including a monthly webinar series. We have a fortnightly reading group where we discuss relevant papers in the field. We hold some ad hoc workshops. There was a series that we held here at UCL earlier in the year, which I recognize quite a few faces from, which is great to see. And we've also been running a field kind of landscaping exercise to try and understand which researchers and folks across the field are working on relevant topics. So who's working on things to do with health equity, generalizability, and so on. So that is almost enough from me. Just popping up the schedule again today in case you want to get the agenda up on your phone. Next up, I'm very pleased to introduce our keynote speaker, Professor Bhramar Mukherjee. Here's the QR code for the Slido Q&A. So if you would like to ask questions throughout the talk, and please go to either pop up this QR code here on your phone, or go to slido.com, and you should be able to introduce this number here. We'll also have opportunities to pass the microphone around at the end of Bhramar's talk. So it's my great privilege and honor to introduce our keynote speaker. Amongst many other things, Bhramar is the John D. Kalbfleisch Distinguished University Professor and Chair of the Department of Biostatistics at the University of Michigan. Her research interests include statistical methods for analysis of electronic health records, studies of gene-environment interaction, Bayesian methods, shrinkage estimation, and of course issues around health inequalities. Bhramar has co-authored more than 370 publications in statistics, biostatistics, medicine, and beyond, and is a fellow of the American Statistical Association and American Association for the Advancement of Science. I won't list all the awards that Bhramar has been privileged with, but I'll just add one final thing, is that Bhramar and her research team took an active role in modeling the coronavirus throughout the COVID-19 pandemic, especially in India, and her work has been covered in major media outlets, including Reuters, Der Spiegel, and our own BBC. And I'm very excited to welcome Bhramar for her keynote, and I hope you'll join me in applauding her.
Thank you so much. Those of you who are here in the room can see that at the back of this podium, it says, remember the days of old, consider the years of each generation. So Brew is definitely from another generation, and my talk does not have any QR code. So it's an absolute privilege and honor to present our work here this morning to all of you. Welcome to those who are on Zoom as well. I did this trip to give this talk because I really believe in what you're doing. And I was talking to Brew that every professional society, learned society should probably have a section on data science and health equity. So, so I just wanted to say thank you for all of you who are involved in this work, all the sponsors, because it takes a village to do this kind of work, and also get rewarded in traditional statistics and promotion system to get rewarded for this kind of work. So thank you very much for this initiative. So the title of my talk is The Data Struggle of the Unseen. So it's a very interesting topic because I think that statisticians forever have wondered about selection bias, missing data, whose data am I seeing, representativeness, generalizability. This is something that we bring to the table, which other disciplines probably do not pay that much attention to. So who is in my study? And often we get very jazzed by the output of the data, output of learning algorithms, but what goes as input? So you'll see this literature that S equal to 1, S is a selection indicator, and that's just a recording indicator in the data set, which could be a product and byproduct of a multitude of factors, which could be non-response bias, which could be inclusion bias, which could be information bias. But I have a target population often in mind to which I want to generalize my inference to or my prediction to, but I only have an internal sample. And most of the time, it is drawn from a source population that could be same as target population or may not be the same, but whose data I'm seeing. So I'm going to design this talk in design this talk in 3 parts. So I'll tell you a little bit about myself, because the kind of statistics that we do, the kind of academic work we do is really entrenched in who we are as people. And for the longest time, when we are in graduate school and we are trying to get promoted and tenured, we really decouple our social and individual identity from our scholarly identity. But in old age, we come back to that. So I like to be very candid about that. So I want to talk about global data inequity. So instead of health inequity, I'm going to focus on data inequity and how does that relate to health inequity. I'm going to set up the context. And then I'm going to pitch a new idea to you that it's not just about the methods. If you're unhappy with the data, you have to do something about the data process as well. You have to really change how data are collected, on whom data are collected. You have to be involved as statisticians in big projects in your university, in your institution, in the nation, so that this gets changed. And then the third point I'm going to try to make that till that happens, till that dream is realized of having equitable data, which is representative of the world, then we have to use our skill sets to do the best possible analysis with imperfect data. And the COVID modeling in India was a perfect example of that. So I'm going to share snippets of my own experience in order to make these 3 points. So as I said, that who we are as people, what do we believe in, what is our philosophy in life, really governs what is our philosophy in statistics. So I went to the United States. I grew up in India. When I was 23 in 1996, I went to the United States, like many immigrant scholars, to pursue my doctoral degree in statistics. And I wanted to be a theoretical statistician because somehow I felt that I was a failure of a mathematician. No offense. But then I quickly realized that probably I'm not so good in theory. I'm not so good in mathematics. But all my life, this is me as a young child, I grew up around very strong women, my mother and my sister. And I also never smiled. I did not like people. And so it really is astonishing that I ended up working in public health, where the root word of the public or publicus is actually people. So I grew up in Kolkata, and my family was really a full of liberal arts family. Nobody likes math. But I had to really pursue mathematics in a very hidden, covert way. I would actually hide my math book inside novels so that my father thinks that I'm pursuing literary criticism or something else. This is usually the other way around. I did my undergrad in a liberal arts college in Kolkata, and then I went to Indian Statistical Institute, which is an astonishing institute for mathematics, computer science, and statistics. And then I went to Purdue. And so far, there is no biostatistics, no public health. I even started as an assistant professor in statistics department, where I did not really have to talk to practitioners. I do not have to really deal with messy data. Then I moved to Michigan Biostatistics due to personal circumstances, completely serendipity and happenstance in 2006. And I have had a fantastic time changing as an academic, changing as an individual at the University of Michigan. And I started there as assistant professor, and as he has just mentioned, that was recently appointed as a distinguished university professor. So I feel that I have done all ranks, all possible ranks, and know the struggles of each possible rank in the last 17 years. But I also want to tell you that I was the first non-male chair of Michigan Biostatistics. The department is one of the oldest, kindest, finest biostatistics departments in the world. It started in 1949. It took us nearly 70 years to appoint a non-male chair. So my perspective on inequity, data, opportunity is really stemmed in who I am and the opportunities and the education that I have had to have this privilege and this right of presenting the talk here. I'd like to quote Dr. Janet Norwood, one of my favorite female pioneer statisticians, who said that women do have to take advantage of the opportunities presented to them. It often quite isn't as straight a career path as it is for men. So you have to seize the moment when opportunities are presented. 5 years ago, I became the first non-male chair, and I'm very thankful that I took that position. But in my work, as I said, that I grew up in a family of liberal arts, so my readings were very grounded. My father is a quite well-known actor in India in plays. And so I asked myself this question, and I ask all of you in this room and in the virtual room this question, that what we are doing today with AI, with climate change, with all of the radical transformation that's going on in the society in terms of equity, this fundamental question that our time in this world is short-lived, but will those people who live after us in the course of 100 or 200 years, will they remember and speak kindly of us? And this question was asked by one of my favorite characters in a play, Uncle Vanya, by Chekhov, Mikhail Astrov, who is a sort of eccentric conservationist. But I find that that novel had a lot of important messages about the environment and climate change. And I can see that that was one of the first readings that I had, which made me aware of the world that we are living in, and the climate and the temperature and the forest and the green space around us. So there was actually a running in the last theater season in the Duke Theater of Uncle Vanya. It's still very relevant. So we are really standing. I work at a school of public health, and I always tell myself every morning that I love AI, I love statistics, but my job is not just to predict, but to prevent. And I must never forget that as I get jazzed by my algorithms. My job is not to figure out who is going to click on which commercial or which promotion in order to maximize my profit. My job is really to prevent and improve human health. So I really think that public health is changing. Public health is becoming broader, and we are thinking about public health as an overarching scientific and scholarly paradigm to come up with solutions which will make the world a better place. And the whole planet's health is involved in public health. And it's becoming a principle for social and global solutions. And so this is really a transforming moment for public health, because public health, if you think about the 6 departments in University of Michigan School of Public Health: environmental health, epidemiology, biostatistics, nutritional sciences, health management and policy, and health behavior and health equity, these give us the tools to work across disciplines and communities. It really deepens our understanding of the biology of health, because we collect data from diverse population, and we have a way and approach of integrating data from our various domains of existence: physical, mental, emotional, and social health, and taking the message from cells to society, really getting data from diverse communities. But the question is, do we have data to really tell the stories and the narratives from diverse communities? I really think that many of us work in a particular disease area. I work a lot in cancer. I work a lot in maternal and child health. Many of us feel connected to a disease. And this whole uh, framework of finding the etiology of disease and why disease is happening, and also improve the disease outcomes and healthcare delivery, is the foundational principles of public health. But is health defined only in our clinics and in our hospitals? I would like to argue that public health makes health broader, because it is in our home, it is in our sidewalk, it is in our grocery stores, it is our school cafeteria. So if you look at the United States, and we do not have national health services, and that's one reason we have a very fragmented electronic health record and data system. But also, if we look at healthcare or treatment after disease as the solution, then you will see the very interesting story in the United States. So this is the cost, health consumption expenditure over time in the United States. And here is the next band is actually comparable country averages, and it tells you that which countries, Germany, Netherlands, Sweden, France, United Kingdom, all of them are included in the comparable country average. And we are paying a lot more than other peer countries. So we'll expect that our health is also better as consumers of health. But it is actually reverse. And if you look at this drop in life expectancy in the last few years, it's quite shocking what is going on in the United States. A lot of it is COVID, but not all of it is COVID. So where do we look for solutions to improve human health? So I think the real power of public health is to go back to the social determinants of health, not only look at healthcare delivery and post-disease events, but pre-disease events, and look at structural problems in our society. And I have listed some of them. And so many of them, and if you look at each of these diseases that I had put forward in the previous slides, all of these contribute probably to each of those diseases, many of those diseases. So we really need to think about the societal solutions along with the disease background. And many of them are actually arising from inequity. So in the United States, there is a very nice model of ranking the health of every county. It is really informed by data, but it is really data coming at different stages. So it is coming through policies and programs. It is how policies and programs can influence health factors and eventually leading to health outcomes. And my slides are with Brew, and Brew can probably generate a QR code. And so if you look at this model, there is a clinical care, of course, the quality of clinical care But health behaviors are extremely important. Social and economic factors, physical environment, air and water quality, the foundations of public health. I love big data. I love genetics. I love electronic health records. But I always think about the foundations of public health and what are basic human rights. So um, it's also a defining moment for data science. I consider myself very lucky. I was having a conversation with a friend, and they asked me that, Bhramar, can you think about any generation which has gone through the invention of the World Wide Web and the internet, a huge pandemic, and then large language models? Don't you feel lucky that you were using data as your lens to navigate all of these technological and humanitarian evolutions? And I said, yes, of course, I never thought about it. This is true that before the invent of the internet, we used to study very differently. And similarly, our students in the next 5 years are going to study very differently because they are going to have access to ChatGPT and Google Bard and all of these. So we are going to use our white space in very different ways when these technological innovations change our society. So in United States, in February of 2023, there is a bill passed, the Data Science and Literacy Act. And I strongly encourage you to read these two documents, which are actually wonderfully crafted. And very recently, at the end of October, Biden signed the executive order for safe, secure, and trustworthy use of AI. And it was mentioned in Brew's introduction, what is AI? I really loved this definition of AI, which is really broad and somewhat philosophical. A machine-based system that can, for a given set of human-defined objectives, make predictions, recommendations, or decisions influencing real or virtual environment. It actually encompasses many of the tools, because we may argue, is statistics AI? Is machine learning AI? How do we define AI? But I think if you take this broader perspective, you'll see a lot of the tasks that we do, decisions based on, because I always think hypothesis testing is that AI. So decisions that you take is covered in this framework of human machine intelligence. But if we do not think about what the pre-trained data for these AI algorithms look like, then I think we are going to be in trouble. Not for equity, just equity, but also just getting the correct conclusions, correct recommendations, correct decisions. So if you build your best algorithms on very biased data and exclusionary cohorts, and also very conveniently collected data, then if you don't do the right thing, then you're automatically lead to incorrect conclusions, but that will also influence your policy, and in turn could increase inequity and disparity, and that will feed into more biased data collection, and this is going to reinforce itself in an iterative cycle. And so what goes, as we think a lot about what is the output going to look like, but I think that what goes as input into fancy AI model matters very much, and I think we all agree on that. So there is a lot of effort into putting structure on what should be the guidelines. So this is a paper which came out in 2020, I think, that what is if you're trying to publish an AI prediction algorithm, then there should be a particular reporting guideline, as well as a risk of bias tool, just like when you do meta-analysis. There should be methodologies for that. And many journals are coming up. So this is a European Herd Journal criteria, 5 critical criteria for reporting AI models. Reproducibility, clear intended use. I think this is very, very important. The social responsibility part. What are you using this for? Of course, reproducibility and openness in terms of data, adequate sample size, and rigorous validation. But still, which data is this built on? That has to be explicitly addressed, not just the sample size. Where is the data coming from? So I think that in modern methods, in terms of all of these high-dimensional statistics, machine learning, we have forgotten how to ask fundamental questions for big data. Stat 101 question of who is in my study, that S equal to 1, and what is my target population of inference or prediction? Who do I intend to use this for? I truly, truly believe that we have moved so much to learn computer science tools. Every statistics department has a data science master's or a course or a concentration. I do think that the computer science departments owe it to us to have a sampling and study design course. I do think the world will be a better place. I want to say that this is getting incredibly important, particularly for big data. And the reason for that is very, very simple. I'd like to really convince you that these type of tiny biases and design biases are becoming much, much more important because of massive 100,000, 1 million, 5 million cohort and biobanks giving us this sense of precision that we really do not have. So if you think about big non-probability sample, suppose that there is a little bit of bias in your parameter estimate because it's not representative of the population. And so there is a tiny little bias, which will be okay if you have a study of 5,000 people, maybe the confidence interval will protect that bias. But now you really have a sample size of 1 million. So your variance is really tiny. Bias is like this, and the bias is not going away with sample size because it has nothing to do with sample size. And the variance is becoming tiny. So what is happening that your true parameter T is almost always outside the credible interval. Even if you plot predictions, you'll see very narrow confidence intervals. And as a statistician, you think, what's going on here? But you're becoming very, very accurately wrong with greater precision. So if that's your goal, if that doesn't matter to you, inference does not matter to you, then it's fine, but it does matter to me. Similarly, it does matter to me to know why some algorithm works and when they do not, the mathematical and statistical underpinning and properties of AI. So I'll switch gear a little bit because I think I've set the stage that this is very important, the data collection. But do we have data on everyone? What is the review of the literature telling you that what do we have data on everyone and what can we do as statisticians? So I'd like to say that data equity is probably a less known concept, but all of us will probably agree that it should ensure fairness, accessibility, and impartiality in the use and distribution of data. And we should make sure that everyone in the world, regardless of their background or their circumstances, has equitable access to and can equally benefit from data sources. That's really important. This includes both in terms of the availability of the data and the quality of the data. And there are lots of problems here. One is about whether the data exists. And the second step is that some countries are willing to share it and some countries are not, and also the quality of the data. So health equity, obviously there is a more well-defined and well-agreed upon definition that everyone has, and this is in the WHO guidelines, that everyone has a fair and just opportunity to be as healthy as possible. And so human flourishing is a basic human right, regardless of your caste, creed, identity, political beliefs, geographical location. You should have equal opportunity to be as healthy as you could possibly be, and in whole spectrum of health, not just physical health. So it's really about human flourishing. So common principles, if we think about data equity and health equity, there are many common principles which comes from the term equity, because we want inclusion, we want representation, we want access, fairness, transparency, ethics, and accountability. What is the intended use? What is our social responsibility? And then health equity, obviously that equal access to health, and I differentiate that from equal access to healthcare, because neighborhoods matter, our homes matter, our schools matter, the food served in our school cafeteria matters. And then also different socio-cultural adaptation of healthcare delivery. So many of us work on health disparity, health services research, but also to remember this holistic view of health where people have equal right to not just healthcare, but to prevention also. So let us look at genetics. Bree works a lot on genetics. Many of us work a lot on genetics. Many of the biobanks are harmonizing millions of observations on genetics. So this is a beautiful paper in Nature Medicine, really evaluating the genetic data. Where does it come from across the world? And also it does not really articulate the problem. I love this paper because it also talks about a roadmap, a call for action, what we can do as scientists, as statisticians, as geneticists, as epidemiologists, as biologists to change this landscape. So if you look at this graph, this figure, that on the y-axis, it individuals in GWAS studies. And this is color-coded in terms of the different regions of the world. And this is time, right? So in 2016, 81% of the world's genomes were from European ancestry. And in 2021, this number has increased to 86%. I come from South Asia, and this is a segment of what percentage of the world's population belongs. So if it's representative, this figure should look like something like this, right? Because if it's representative of the world, and in particular, look at South Asia. This is a large chunk in the genomic data sets, almost nearly no representation. This hurts because I am from South Asia. I want to know what will happen. I want genetic prediction for my parents, my family. So can I do anything about it? So this is something that I really like, that when we write papers, statisticians often are so happy to prove theorems and do not look into addressing the broader community in terms of and then proving theorems is extremely important. I would not let a student graduate without at least proving one. So, but then I think that this is also very important, that what can change things. And I really like this call for actionable change, where stakeholder will, that we have to have the will to change as a community. We have to build the infrastructure. We have to really get funders to agree on this. And then we have to build capacity in every country so that these studies could be launched. And then global consortia, right? So how can we pull studies from different parts of the world? And how can we get data from different countries, where the cultural practice is not data sharing? That's also an extraordinary challenge, which I realized during my work in India. So there have been efforts. If I sort of see the call for action and where we stand in 2022, 2023, you can see that this global biobank meta-analysis initiative is going to be game-changing, and it has biobanks from all over the world. And as you can see, it's more representative. There is a lot of East Asia, but still no South Asia. So it's important to remember that, we need to solve that data gaps from the world. I work a lot on Michigan Genomics Initiative, and I know many of you in this room work a lot on UK biobanks. We are going to talk about those. And when we talk about some of the analysis, but you can see that there is a lot of effort in the genetics community to pull this together, share summary data or metadata, do federated learning, all of these in a secure environment to get more information. And so I think 24 has already gone up to 26, but this is really good initiative. There is another initiative which is also bringing all the large studies in the world together. So this does not necessarily require genetic data, but it actually has more diverse population. In fact, I think that it has more than 50 million total participants, representing over 40 countries and regions in the world. So I think that these types of initiatives are starting, and the more we work, more we get involved, more we propose projects across the globe, I think that people will find, the invisible will somehow find their voices. So collecting your own data, I think that, so I'm going to switch gears and talk about why I think statisticians should be really, really involved in setting up studies and data collection. But before that, I pause and see if there are any questions on the first part about data inequity, health inequity, anything I have said so far.
There is one in the slide which has a three-part question.
Okay.
No, it wasn't a three-part question. It's one-part question split into three questions.
Sure.
So the first part was that often in public health research, we see studies that do not properly disaggregate data based on race or ethnicity.
Yes.
A common reason for this is because there are fewer ethnic minority participants than white majority participants. How can we use statistics, or what else can we do to try and deal with this data gap, which results in inequitable health discoveries or innovations?
Yeah, so I think so. The question is that if we have a study where there are multiple race ethnicity, then minority race ethnicity in terms of counts are often ignored and not treated because you don't have enough power for discovery and so on. So this sort of goes to the supplementary material and how can you enhance the power for discovery. And I think my next part is going to answer some of that question. And the third part as well, that if you do not have adequate data, what can you do in order to combine sample with diverse population? But this is an extremely important question. And I think I always say this, that when NIH actually mandated that you have to explain how are you using sex as a variable in your model and your study, is it a biologic variable or is it a sociocultural construct represented by gender, then people change their practice. So why not force everybody to write down, I'm putting this in table 2, this race ethnicity variable, what is my intended use? Am I using because I truly believe the rest is different? Or do I believe that this is representing a confluence of cultural, socioeconomic, environmental behaviors? So I do think that these practice guidelines are really incredibly important. And ultimately, money can control a lot of things, and funders and journals can control a lot of practice that we have currently. Yes.
Thank you so much, I guess my query is about often in our papers we will talk at length about the diverse biases using big data, and then we work with policy think tank folks and NGOs, and they just take the numbers and try to really kind of say, okay, well, actually, so it is 3 times more, right? And then again, oh no, well, actually, these are the kind of issues with that. Now, maybe it's not an exception, but I think in the translation bit,
yes,
we can, state all the biases. We should have all of our lists about what's not in there, who's not in there. At the end of the day, it feels that if you don't have that kind of a staff background, you're going to go for the main number there. That's going to be in the front page of the Guardian or BBC. And how do we kind of acknowledge that, especially as numbers are getting more and more and more?
This is so important, and that's exactly why I feel that so the question is that we statisticians are very, very careful about these things, but other people who are just trying to get a number and run to the media or run to a policymaker, they are going to often go for one number, and then the computer scientist who is very faster at producing that number, all our business will go to them. No. So that's why I think that it is really, really important for us to improve, first of all, our scientific communication, and also not let perfect be the enemy of the good. When you are actually, yes, there is bias, there is imperfect data, but if you really think that there is a finding here, do you really care that the disparity odds ratio is 1.8 or 1.9 when you can say that you should have a policy which tries to get it closer to unity? I think we often, if it's 1.2 versus it's in the gray region, yes, you should collect more data, but sometimes we just obsess about details which will not matter for policy impact. And COVID has given me that practicality sense that because the time span was so short that we could not do the practical, usual, typical practice of statistics. But did we produce everything wrong? No. I think it was not perfect, and you revisit, but you still have a decent answer. And I think statisticians often come up with very good, astute answers, but we wait for the perfect. Don't let perfect be the enemy of the good, and be very strong and vocal and cultivate your communications. I think these are two of my advices. It's a battle still. Yes, please.
So I really liked your figure on the vicious cycle of biased data collection leading to biased decision making. And some people I've talked to, many minority groups, feel that because of this, they've lost trust in the healthcare system and are less likely to participate in clinical trials or even give up their data, even though we feel we're trying to help them. How can we sort of fix this mistrust?
And I think this is a great question, that how can we see that this biased data, how can we break the vicious cycle, and how can we earn trust of historically excluded communities to have their data? I think you'll see some of those glimpses into the second part, but I have to tell you that I'm on the external advisory committee of a Superfund project in the United States, where we are studying the Native American population in South Dakota. And it is really, really important to build community trust. And we are working with a scientific organization which is arising from the reservations. And it is incredible. When I went there, they actually, in their tribal laws, they have a data sovereignty clause that the data belongs to them and what is the process. It is very, very mature, and you have to be really respectful of that. And it will take years to earn that trust and say that this is the correct story and build partnership. If you work like, I'm going to get the data and disappear, and there is no return to the community, no respect to the community. During COVID, we saw this with vaccination. Even in the state of Michigan, we had to build trust and community with a lot of religious leaders, faith-based groups, in order to penetrate into communities and increase vaccine uptake. So the strategies that work for recruitment and doing science in one community is not, and that it should not be. It should be socioculturally adapted. And it's much harder, but that does not mean we should not try. And hopefully I'll give you some hope in the next segment. Okay, so collecting your own data. I will tell you this story. This is pre-COVID, 2015 to 2017. I had just been promoted as a full professor, and I could not see why am I doing the work that I'm doing. And it seemed very boring and similar, and I was having a complete midlife crisis with my academic identity. So there is a genetics talk with a big GWAS study, and I sort of raised my hand and asked, like, when is a farmer in India going to get genome-wide scan done and have personalized medicine? And so that did not go very well. But I also realized that I need to do something which takes me back to my roots. I do this fancy statistics. I'm in University of Michigan. I'm extremely privileged as an academic. I need to do something. So I applied for a little pilot grant about monitoring maternal and child health in 15 villages in West Bengal. West Bengal is the state from which I come. And we trained the community health workers. So you can see one of our community health worker comrades in terms of collecting data. So many University of Michigan students, you can see them here, went to train the community women into how to collect data using iPads. And what we did was collect very basic questionnaire data on early childhood learning and maternal health outcomes, and create a very simple decision tree in Michigan. As soon as they collected the data, it actually got stored in Michigan. I worked with a team of information scientists there. And the challenges with translation. India has so many different languages. And if you go to these communities, you have to have the ages and stages questionnaire validated in 46 different languages. So we focused on Bengal, because I can translate the Bengali questionnaire. And then we did this project. And we did go into communities and did these measurements. And there was a simple tree algorithm which predicted who is at high risk of prenatal complications, who is high risk of learning disorders. And we took a mobile van once a month into those communities to provide some basic clinical care. And that tree algorithm is not publishable. Absolutely not. Many of my colleagues who are big biostatisticians and theoreticians asked me in the department, what is happening to you? So, I really like, sometimes you'll have to answer those questions, what's happening to you? And this was my first senior author paper in non-statistical journals because I collected the data. I came up with the idea. I collected the data. These are not big papers, but it gave me extreme joy and satisfaction of, well, I'm using my resources to do something which is very meaningful for me. And we can talk about what, some of these ideas of how to do health monitoring has really been widespread, and people have been adopting that. One of the things which came out of this project is this community health workers. There are 9 of them. They, in their exit interview, said their families, their husbands respected them more because they were collecting data on iPad, which was going to the United States. So these are some, strengthening women and their role in families was not a goal of this project, but it was a very unexpected and rewarding byproduct. So in my madness, so this work was mentioned a lot, that because I always felt connected to my root in hyphenated identity. So on March 16, 2020, when the stay-at-home order started in Michigan, many international scholars, particularly from South Asia, were feeling very lost. And I felt like, as somewhat of their chair and leader, I needed to do something. And we could not really go and work in the front lines of healthcare workers. What could we do? We have skill sets with data and model building. So I very quickly put together a group of programmers and coders and website developers to model the pandemic in India. We were not infectious disease modeling group, but I was seeing that in Indian media, there was a lot of comments from people who did not have their immediate expertise in modeling. And also there was very few non-male members in the media. And I just felt that we have to do something to keep this community together. And if we probably model and see what the trajectory is going. And I also wanted to think, I want to do this for my parents. And so this is a picture you see, last summer, I went to India, and this is the chairman of the India's COVID-19 Niti Aayog. And I have never met him, but I have answered his call at all odd hours, literally 2 a.m. in the morning. So this was a nice visit in person after the whole ordeal was over. So it was a very huge undertaking. And we started modeling the pandemic from, again, March 16. So March 2020 was our first paper in Medium, which made a lot of headline news across the world. But we really started modeling it from March of 2022, and our app really ran till 2022, 2020 for 3 years. And so there was the number of deaths. At the time, India had about 500 cases and 11 deaths. And we stayed with the pandemic, and we created an app which became sort of the go-to destination. And again, the app used a published model, couple of published model in order to come up with predictions. It was not methods development, but it was a very useful contribution. We also provided models for all Indian states, and many of the smaller Indian states actually do not have official statistics and modeling capacity. So this was incredibly helpful. But I also got into a lot of trouble and controversy because I was talking about underreporting of death data in India. So, and to the media, and writing articles that in Indian newspapers that bad data is really hurting India's fight. There is some data paucity, but there is also data opacity. Some of it is just through the system, some of it is designed. And so I just spoke that from all the modeling that we have done, we believe the true number of deaths is 5 times, 2 to 5 times. And it's an extremely conservative estimate. If you look back, we were just doing modeling in terms of the infectious disease models. But when the data came out, the WHO, the IHME, everybody said that when India was reporting 600,000 deaths, the actual number is at least like 4 to 5 million. So that if you take all the studies that came out and take the lower bound of the lower confidence interval, you get 7 to 8 times more than the reported deaths. But at that time, we were only using the infectious disease models. So it was, at the time, it was very dangerous to talk about it. It was the height of the second wave, and a lot of people, it was really brutal in India. My own family, many of them were hospitalized. So I also tried to build coalition. I went on CNN and said that this is not India's fight. The world needs to pitch in. And you know, there are a lot of people who resonate when you actually have an appeal out. We immediately formed the India SOS. There are several epidemiologists and medical doctors and engineers in the US and abroad who came together to send SOS help to India. And it was a really different process. But my father forwarded this to me, that you're never coming back to India. This was a WhatsApp meme shared with him. And again, you mentioned that you provide all of those uncertainty bands and so on, but this is what the media runs with. That if the Modi government acted in time, then this many deaths could have been avoided. No confidence interval, no qualification, no scenario of all of the simulation studies and counterfactual generation, just one line which will hit the headline. So it is very difficult in those moments when to stand your ground. Because as statisticians, you are not expected to. You're working behind the scene and suddenly you are in the forefront. So it really built my character, because I definitely made my own mistakes, but my mistakes were not driven by any agenda. They were genuine scientific mistakes. And after that, I do feel that I have written many, many papers, but the work, the contribution of this work, the reach of this work, the impact on me has been really astonishing. And that was really a moment of madness when we decided that what else can we do? In your life, when you are confronted with some choices where you have no other choice, then I think the road becomes easier. We did not think or envision the impact it will have, but it has been really, really impactful. So after COVID, I really had an identity crisis. Am I going to do this kind of work, or am I going to just go back and legitimize myself again, recertification as a biostatistician, card-carrying biostatistician? So I said that I have to do both, because I love biostatistics. I love math. I love the methodology. I like to think about problems through equations, but I cannot give up what I really felt, my connection to India. So I had my sabbatical in Cambridge, and I met with some people who are really studying climate change and coping of increased heat in India. And it was right in front of my eyes, but I'd never have thought that women and men cope with heat in India in a very different way. And women are most of the time cooking and not always in a well-ventilated kitchen. In terms of socio-cultural practices also, in terms of clothing, in terms of going outside, they have restrictions, and often they don't feel the financial and the economic empowerment and agency to actually turn on the electricity. Many times the single air-conditioned room in a household, the key belongs to someone else, the head of the household. So all of these cultural things were there. So, but now we are thinking about and trying to get data on how can we quantify this gendered effect of heat. So I feel that little bit of data activism, which I saw had benefit, I'm not going to give that up. So I also want to share one story, that building better data resources. And so the time period I said forever. So this is something in Michigan, right? So this is more sort of up my alley in my own institution. So we have, the university has its precision health initiative, where this is the Michigan Genomics Initiative, where we link electronic health record with genetic data. And it has been a longitudinal biorepository started since 2012. This is my bread and butter research, EHR and genetics. And so we had really created, when COVID happened, in over a period of 8 or 9 years, many people, Gonzalo Abecasis and Chad Bhramar and many people from medicine and genetics created this data repository where we actually had linked the core elements, the electronic medical records and genomics, with epidemiologic survey, which is like UK Biobank, but also medical claims data, dental records. We had mapped the residential location to air quality and some of the socioeconomic indicators at a census tract level. And we also bought some data. So we had created this integrated digital ecosystem in Michigan, and I was involved in this process from the very beginning, not as a statistician, but actually in charge of cohort development, who to collect data on. So when COVID happened, we could layer the COVID data, the vaccination, the infection, the long COVID, the symptom survey data on top of this integrated data ecosystem. And not only that, we had a very engaged participant community. We could, we always stay connected with them with this app. And this is really a fantastic app, which is used for NIH All of Us study, Framingham study called My Data Helps. And so, again, during COVID, most of us were probably spending a lot of time with our phones. It was a great time to launch out some of the epidemiologic questionnaire as well as a COVID survey. So I strongly encourage you to, like, modern data collection methods could also be very relevant. And again, you can ask that question, S equal to 1, what is S equal to 1? So in May and June, a team of us rolled out a COVID survey for Michigan residents in our catchment area. And again, there are many big surveys and many Facebook and Meta, and I have worked on many of them. But again, close to home, how are Michigan residents feeling? Is our catchment area, our participant community who has given us so much data, they are feeling? To be able to write papers on that was really incredibly important. But then coming back to it 2 years later, I asked myself this question. I had access to EHR and people were getting tested and hospitalized in the EHR itself. Did the survey add anything? So later on, you could not do many of the subtle statistical questions during that time. You have to return to it. As statisticians, I think that there is a need to pursue that truth as well. So we did that later. Even in a very liberal and very well established footprint in the community medical center like University of Michigan, during COVID, we noticed that the health outcomes, the COVID outcomes were not similar across communities. And you'll notice that most of my COVID papers, there are many clinicians who are involved in the team, but I actually am the senior author because I decided that we need to talk about these problems. And so what we articulated is the differences in outcomes of Black and white communities, and also followed that up 1 year later. Have things changed, right? So initial paper in 2020, 2021, have things changed? So this was our initial paper. And as you can see, that we showed that the hospitalization, ICU admission, mortality, all of these outcomes were higher portion in the Black communities. And because we have layered all of the data, most papers at that time were presenting just unadjusted estimates, but we could do a much more sophisticated modeling because we had all of that. We had genetics, we had social determinants at an ecological level, but we had much more data to come up with fairer or maybe under different circumstances and causal models estimates. And I'm not presenting table 2, I'm just presenting my target parameter under different adjustment. 1 year later, what we saw is that, of course, thanks to vaccine and improvement treatment, every bar graph have come down, but still not at the same rate. Disparity exists. So I think it's important commentary in terms of available data to first show that these things are happening even in a medical center like Ann Arbor, University of Michigan, where the medical care is phenomenal. So during this study, this is a very fascinating story that in terms of data collection, this is my last story, I think, in terms of data collection, that when we are doing all of this Michigan Genomics Initiative, we host participant community engagement studios. And then the participants tell us what do they want from us in terms of research input. And they asked us that you're doing so much in terms of COVID and in terms of genetics, but Michigan has been a place where a lot of environmental disasters happen. Are you not collecting any data on the environment, air quality, the metals exposure, the lead health crisis that happened in Flint? So we decided yes. So with two of my colleagues, Lee Pierce from epidemiology, fantastic scientist, and Dana Dolinoy from environmental health, we proposed a project, which is the data that I want. This is the dream data set of a truly prospective cohort of 100,000 patients. We are oversampling from 6 environmental injustice hotspots in Michigan, because Michigan is the site of many environmental catastrophes, high PFAS levels, air pollution, Flint water crisis, lead in the water pipes. And so we were collecting data. So what we did is to create environmental injustice score, which is actually an index that EPA and many other states have for the state of Michigan, and oversampling from the environmental injustice hotspots and this 100,000 patient cohort. These are healthy individuals, and we are prospectively, before the disease happens, going to measure repeated measures of metabolomics, epigenetics, immune function, survey questionnaire prospectively. So many times, those of you who do omics analysis, you probably feel the lack of repeated measures. And our target is to have equal participants from Black, Latinx, and Middle Eastern, North African participants. It's a huge community in Dearborn near us, so that we can really tell the stories of everyone. So only 95,000 more to go. We are at 5,000. These are some of the community events that our students, our scholars are going. They feel inspired. They feel a bit of like, they're much more idealistic and altruistic, the times of the generation. So this is the part where I wanted to say you can do something. Even as a data scientist, you can do something. I'll quickly like to go through the last part and then take questions. My plan was to take questions, but I'm really running behind. So I want to say that I have, Brew told me not too many equations. And so, everything that I have showed you is not it's not tenure worthy. It's not tenure worthy in a biostatistics department at University of Michigan. I can tell you as the chair, and I know this is being recorded. So, can we change the metrics? Can we change the metrics of incentivizing that? Can we get promoted, recognized to do this work? I do think that we are biostatisticians, so we of course have our own discipline. This work is important, but it's also important to think about how do we optimally analyze the data that we have, and what is our skill set, our math, our coding, our modeling, our study design senses are giving us. So I just want to end with a snippet of an example that we are working on. I showed you that Global Biobank Meta-Analysis Initiative. So different biobanks are being put together. Michigan Genomics Initiative is my favorite biobank. This is my community. I know many of the participants in this study. It is actually being recruited. This has nearly 100,000 participants now. It's being recruited when patients are actually waiting for surgery. It's recruited by the anesthesiology department, a peri-operative recruitment. 50% people in this biobank actually have a cancer diagnosis. So obviously not representative of the population. And then of course, UK Biobank, but you have to remember, it's also 40 to 69, and it has been articulated that it has a healthy control bias. I'm going to show you in a moment. So recruitment mechanism, my S equal to 1, the mechanism for S equal to 1 is changing. And maybe the source population and target population is also changing. And then NIH all of us, which is 1 million participants, and oversampling historically excluded groups. So now if I want to do an analysis putting all the biobanks together, and you can imagine the 24 biobanks on that map, some are eye biobanks, some are recruited in terms of cardiometabolic diseases. So how when I put that together, how does that look like? So I have been doing a lot of work on how to handle selection bias in terms of, so the methodological work that we do really dovetails with what we want to talk about. So this is for Michigan Genomics Initiative. We have done a lot of work on how to think about selection bias, how does phenotype misclassification and selection bias work together. And there is also a lot of papers coming out that you might think UK Biobank is nationally representative, but also there is a participant bias in UK Biobank, in participant respondent bias, but also in terms of the age group and the healthy control bias. So how do we think about this problem? Does it matter? Does it matter? And I think that we really have to think about the question in terms of what is your inferential task? Are you interested in prediction? Are you interested in estimating disease prevalence? You can probably easily say that that's not going to work, because 50% cancer in Michigan Genomics Initiative, under-reporting of cancer in UK Biobank, and over-reporting in NIH all of us putting together does not make much sense. If you wanted to just do a phenome-wide scan, disease exposure association, does it matter? Does it matter when you're trying to talk about causality and estimating a causal effect? So how do we think around selection indicators? I'd like to really posit this sort of like a 3D framework, where NIH all of us has a well-designed survey mechanism through which it's over-sampling certain individuals with certain characteristics. So in a study setting, if you have observations from a finite population, capital N is the population size, and S is that indicator through which the ith person's data gets into your sample, right? Forget about like inclusion, exclusion, selection. It could be a different mechanism, but the sample that you're analyzing, SI equal to 1. So many times survey researchers deal with this design probability, and many of the national surveys have survey design component where this probability is known, right? It could be equal, it could be unequal, but you know this probability. The problem that we are having with biobanks and electronic health records is that we do not have this sampling probability. It exists. So I'm going to call that divine probability pi exists, but I don't know it. What I know is actually the device probability, or the statistician's best guess at the divine probability. And you could do machine learning there, you could do a logistic model there, and so on. How do I really think about the design to the device probability to the divine probability? So it would all a pi hat will always be a sort of a approximation. And this technique is used in missing data, is it used in selection bias, and many times similar to causal inference as well. So how does statistics help? So you are really after this model, this association, say, in the model with D given Z, that's your real model of interest. And you have some kind of device probability for modeling the selection mechanism. And here my notation is that Z1 and Z2 is the variables which is common to the two models, both say age and sex could influence both of these models. And W is unique variables in the selection model. Z1 is the unique variable in the disease model. And this selection, it becomes much, much more difficult if selection depends on the disease itself as well. So the question is that we actually, in this paper in biometrics, we show that you can relate the model that we are fitting on just the selected sample, right? This is the one we can fit because we do not know S equal to 0. We do not know that. The model that we are fitting is related to the true model through a identity. And this identity, it's not easy to come up with this offset term, but you can prove this idealistic result. If I knew all of these ingredients of this model, this is how it's going to look. So math helps in order to think about the offset term, and many of us who are familiar with case control studies will just immediately think if it did not depend on Z1 and Z2, it would look like that offset intercept term when you do outcome dependent sampling. But here outcome and covariate and selection, everything is tied in. But this gives you a mathematical framework of studying selection, that when would things be sort of unbiased if there is no pathway with the disease model and the selection model, and when you are not going to be able to, you're not magicians, so you are not going to be retrieved and remove selection bias when the DAG is quite complicated and everything is coupled together. So in a recent paper, we really evaluate many methods, which is essentially based on doing an inverse probability weighted logistic regression. How do you build these weights, and how do you actually make inference in these cases? And so again, this is an archive paper, and basically we cannot do everything from nothing. As I said, we do not have S equal to 0 data. We only have S equal to 1. So we need some external probability sample. So we need some national data in order to build these weight models. And that could be individual level data. And there are methods for using individual level data. Or it could be summary level data, which is more realistic from large studies. I know the margins. And statisticians have come up with many methods in order to deal with this situation: post-stratification, calibration, simplex regression. And in this paper, we actually evaluate all of these methods under these different selection DAGs, and then say that which method is likely to work. This is our job, to study, to do proper simulation, to say that when the selection model is correctly specified, the selection model is misspecified, what happens to the properties of the method. So I do think that if you care about a problem, you really approach it from many different points of view. So I'm going to skip the next 3 slides because I'm at time. This is sort of showing the analysis when you do different kinds of weighting. And I'm with the 3 biobanks. Sorry, we can come back to that. But we actually sort of really looked at this putting biobanks together when the tasks are different, right? There is no single answer. That's what I'm trying to say, that you can try to come up with these weights, but your answers when you need weights and when you do not, to weight or not to weight, that is the question, will depend on when you are trying to do association versus estimation. So the takeaway I want to end is that weighting to recover the analysis, that if you have underrepresentation, and weighting to make it look like it is the national population, it may not be always the solution, because many times in this biobank, I do not know the selection mechanism, I'm misspecifying it. Using for estimation of prevalence, estimation of a causal effect, selection bias really matters. Less crucial when you're looking at correlation across the phenome, or you're conducting agnostic association testing where p-values and uncertainty estimates may matter, but it matters less because sometimes in a test statistic, selection bias operates on the numerator and denominator in a similar way. So the ranking often is preserved. So you really have to think carefully through your mathematical lens. All the courses you're taking in inference and probability come back to data and come back to equity. But I do think that I am a data dreamer, but I'm not the only one. I'm glad that you joined us, at least this morning. You have to invest in building the capacity, building the data dreamers of the future. For the last 8 years, I have been running this summer program where we bring in 40 undergraduates. You know, I'm old and jaded. My time is done. I'm not going to come up with big ideas anymore. But I can actually provide a platform to the data dreamers of the future. So from 2015 to 2023, we have trained 326 data revolutionaries, and they are changing the world, one algorithm or one theorem at a time. I do not care. But thank you all for listening, and thank you for contributing to the data work for the future.
I think we should take at least a few minutes of questions, and then we can go to coffee. So there's one from the Slido, which I think I'll try to expand on. So the question is, what is the work that needs to be done to bring the non-clinical data insights close to healthcare? Are the incentives for healthcare the main blocker? I guess I think there's a maybe a question around that around how do we bring data on like social determinants of healthcare? To ask about your experience working with non-statisticians and any advice you can give that.
Okay, great question. So social determinants of health. In my slides, there is a link to a Time magazine article by some two authors who are members of the US National Academy of Medicine, actually calling the hospitals to invest a part of their profit into collecting data on social determinants of health. And so I think that the industry partnership and the hospital partnership is very, very important. So let me see. I think I put that link in there because of this paper. Yeah, so I think it's this paper that in Time magazine is sort of in here. American healthcare is broken. Major hospitals need to invest not just into the treatments, but also understanding in their catchment area what are the social determinants of health, and also for each patient have a profile in terms of the social determinants and also have better data. Also repurpose to change some of these social determinants in terms of community projects and investment back into the community. So I think that this is a very important message, but also really understanding joint modeling, right? So what we had was census tract level data, but still that is something. But again, if you have census tract level data on some people, individual level data on some people, then again, we can use some of our statistical tools in order to build the data quilt, the patchwork. So I think it's incredibly important for investing and connecting and funding grants which have a RFA that you need to integrate social determinants of health into your EHR. And surveys are also very important. And these new modern tools of survey are incredibly important because people may have survey fatigue if you are just giving them a long survey. But when in an app, a question pops up that did you take your best walk today? Or one or two questions, people are probably answering that in a more loyal way and sincere way and accurate way.
Yeah, my questions are around the data inequities, and I've decided that you shows that most of the world outside the US Europe and
yes.
are marginalized groups
yeah.
In terms of getting data. And at one point you touched upon that one way to sort of close that it could be people volunteering data to community science. And of course that's it is a thing of related to some of the bias. Multiple people and working percent in the end. In the UK, we had during the pandemic, there was some an app you could install where you could use loggers and one paper was published on it where it concluded that if you're taking antihypertensives, you'll probably have more problems with COVID and they were tracked. And of course, the people who were installing this and reporting it and reporting all this into the borders, and it's pretty known that if you were cardiovascular risk, you were more at risk of COVID. So I guess it's sort of an example of where not to volunteer data. The same could go for a lot of marginalized groups where this is not a pharmaceutical market in outside these regions where so the data is not there, and so sort of these things to try and make the sort of the beginning and the end of yourself.
Yes, so I think it's so you just said it, right? So many times we rely on volunteers and every kind of bias actually comes in. I really learned a lot by looking at the data from the different biobanks and what kind of biases it can give us, because it's all really thinking in a statistical framework very, very important, because if what is determining selection is not related, if you're looking at a different question where the D given Z1, Z2, the association question that you are trying to answer has nothing to do with the selection mechanism, then you are actually can retreat. So many times, if you look at Michigan Genomics Initiative, which is a highly biased, like highly disease sample, you can see like in cancer, diabetes, so much higher in Michigan Genomics Initiative, as well as, right, because this is okay. So there are some diseases which happen with a higher incidence in some communities, and if you oversample them, then your overall prevalence rate goes up. So I think this is very important to look at these biobanks in terms of the disease characteristics. Many times in genetics, the value of a single nucleotide polymorphism, which you're born with, your genetic, like if your DNA data, often is not related to too many things. And that's why the odds ratio of disease and single gene are often better case studies where it's actually close to the gold standard population, even in a biobank. So it's really, that's what I was trying to say. It's important to think about those DAGs, the question that you're trying to answer, and the selection mechanism. It's very important to really look at this figure for every study. What really led to influence my selection? And are those related in terms of the DAG to the inference question that I'm leaning to? And many times in prediction and other things, it matters less. But I think it's very important to understand that when it is going to create a major problem and when it is not. And that's where the statistical lens really helps in terms of self-selected sample. And there was a paper in Nature by Seth Flaxman's group using Facebook data, how vaccine uptake was so overestimated using Facebook metadata. And that's very reasonable because people who are getting vaccine are respondents. So the respondent is really, really the outcome, and the chance for responding is tightly correlated. But if you're not, if you're looking at something else, maybe it is useful, or relative changes or time changes. So what estimand are you interested in really matters. And that's why I feel like we're very blessed as statisticians to have the lens to look at this problem and say, oh, for my inferential problem, do I have all of these differences in the three cohorts? Can I use a target sample and do weighting and get it closer to my target representative sample? So these two are my UK target population and US target population. Do I want to map it as close as possible and then do meta-analysis? Yeah.
Good time. We'll have one more question in the room and then we'll
Thank you for a fantastic talk. It was so refreshing to hear your personal backstory and really inspiring. So thanks for sharing all of that. My question is about the quality of ethnicity data, particularly in routinely collected data. In this country, we have a big problem with the quality of hospital-collected ethnicity data in that it's not self-identified, and we don't collect it on death certificates either. So sometimes we can link to census data, which gives us that gold standard self-identified ethnicity data, but that's quite rare. You don't see that many linkages of census-based health data in this country. So I wondered if it's a similar problem in the States, or whether it's different because of the insurance-based system. And yeah, what your thoughts on that are, how important is it, and whether there are initiatives that you're aware of to improve the quality of ethnicity data in routinely collected data.
Yes, so the question is very, very important, and US same problem. The 5 categories of ethnicity, that is, you are sort of furnished to choose. Many people will go to other because they cannot identify themselves with any of those characteristics. So there is, in terms of race, ethnicity, combination variables. So there is a lot of push, there is a lot of literature to have more categories. Just as, in gender, in other things that we are recording, the world is changing to have policies in place so that people have option of seeing themselves in the categories. That's also about inclusiveness. If I don't see myself in the very first 2 questions, why would I actually want to participate in the rest of the survey? So I think it's very important to have policy change. And again, that's why I mentioned that NIH's sex as a biological variable or not really force people to think about. Similarly, when you are using race, ethnicity as a variable in a model, if you are forced to say, what did you measure? What were your choices and what are the limitations of this variable before you start doing effect modification or stratification or confounder adjustment? I think that that would be really, really relevant. But we have the same problem. And what we also see, this is very, very interesting, that the EHR reported race, ethnicity and the self-reported, when you have a survey with much more detailed, because that's in the investigator's hand, gives much, much more information. Also, having genetic data helps because we can then decouple ancestry from what is self-reported race, ethnicity. I think this is also very important for the biobanks to have that, because we can map to the genetic ancestry as well. So having more data, but also making a proactive push so that there are more drop-down categories so that people can see themselves in the data set.
Thank you very much. We have one more question online, a short one.
Okay.
What's your call to action? What's the one thing that we as data scientists can do to improve equity in our work?
So that's a great question. So I think that throughout my talk, I tried to say that wherever you are, whatever you have, get started. And I think if this is a principle that you feel, if all of us feel that as data scientists, we want to see more equitable data, we're going to take small steps. That's why I showed my little snippet of 2015 and 2017. And by little steps by everybody, it's going to really change. I give this analogy, my students laugh at it, that in these big social movements, I really like ridge regression, where I have distributed signal across all variable rather than lasso, where only 2 factors have signal. We all need to do a little bit more, and we are not looking for a sparse solution. And if we all change our writing, even when we are putting like the discussion section, if we all think about that, how should we interpret race, ethnicity, genetic ancestry, if journals and funders all come together. I really dislike it when we blame it on the system. We built this system. I'm the chair of a biostatistics department. I can talk to other chairs. I think we have power. And I do think that we should really rise to the occasion and use that power, mobilize that power. And what you're doing in this room, awesome. That's the first step.
On that note, let's give Bhramar a warm round of applause.
Thank you.
So we'll start again in just under half an hour. So we'll shift the agenda back by 15 minutes and start at 11:30 for the next session. Okay, 11:30. No, I just shifted it now. So sorry about that, people online. Just introducing the set of talks for the next session, which you can all see the names on the screen just there. Let me start the video as well. So for this session, we will be in the capable hands of Vanessa Rodriguez and Evan Dimitriou, who will be chairing these talks. I'm going to pass over to Evan, who will be going first.
Hello, everyone. It's a pleasure to invite four amazing speakers that they have done, they keep on doing amazing work on data science and equity. Without further ado, let's welcome Helen, research fellow in applied statistics and statistical epidemiology at the Institute of Epidemiology and Health. To kick off a lineup of amazing talks with an insightful presentation on investigating inequalities for patients with cancer. Okay.
Hi everyone. Yes, my name is Helen Blake. Thank you very much for having me. I'm a research fellow in the NIHR Applied Research Collaboration for North Thames, which is part of UCL. And for the last few years, I've also been a research fellow working in the Clinical Effectiveness Unit at the London School of Hygiene and Tropical Medicine, just around the corner. So today I'm going to be talking about some projects looking at investigating inequalities for patients with cancer. One's from my previous job and one's from my new job. So let's get going. So bowel cancer and breast cancer are two of the most commonly diagnosed cancers in the UK. For bowel cancer, there are over 30,000 new diagnoses per year in England and Wales, and there are over 55,000 new primary breast cancer cases per year in the UK. For cancer in general, there is evidence of inequalities in care and outcomes. So not only is there a higher incidence of cancer in, say, more deprived areas, but we've also seen differences in access to treatments and also worse survival. So there's two projects. The first one is looking at bowel cancer. This was the work that I've been doing at London School in collaboration with the Royal College of Surgeons of England. And then the second study I'm going to be talking about is the breast cancer study, which is a collaboration between UCL and Queen Mary University. So first, the bowel cancer study. So in England and Wales, 1 in 5 bowel cancer patients are diagnosed after an emergency admission, and most of these patients need life-saving emergency surgery, but this surgery itself is high risk. 1 in 12 patients die from this surgery. There are guidelines on the care processes for patients who need emergency bowel cancer surgery, but the evidence for these guidelines is limited. And we've seen differences in access to recommended treatments and in outcomes by deprivation, ethnicity, geography. Some colleagues were working on looking at differences in access to a specialist treatment for bowel cancer, and they found differences by deprivation and also differences in mortality. But for patients who need emergency bowel cancer surgery, it's not known if there are any differences in their access to specialist care, nor what any impact any differences may have on outcomes. So this is actually an extension of the original study. And so the specific research questions for this extension, the first one is, does access to specialist care differ by deprivation, ethnicity, and region? And we're also looking at, do the differences in access to specialist care explain differences in outcomes? So as well as trying to write a peer-reviewed publication for a national study and getting a public and patient lay summary that's patient-focused about our findings. We're also planning to create bespoke feedback for the region covered by the NIHR ARC North Thames, so ARC being the Applied Research Collaboration. So as I said, this is building on an original project, which is a 3-year NIHR grant called Constructing the Entire Care Pathway of Bowel Cancer Patients Undergoing Emergency Surgery to Improve Their Quality of Care. So in this grant, we were looking at using linkage methods to bring together information from several separate data sources on bowel cancer patients undergoing emergency surgery in the English NHS. And we developed a rich data source on patients, information about their tumours, their treatments, their surgical risk, and outcomes of care. And then this has allowed us to then be able to make accurate comparisons between patient groups and also between regions. Throughout the original project, we had input from our public and patient representatives, and I'm pleased to say that one of those representatives is actually a co-investigator on this extension, and she brings her lived experience and helps make sure that our research focus is where it needs to be and what's relevant for patients. And she also helps us make sure that our English summaries are understandable for a lay audience, and she contributes so much. So many thanks to her. So this is only a short talk, so I'm just going to give you a very small snippet of some of the results that we've been looking at. Some of the measures of specialist care that we've been looking at. So there's whether or not there was a consultant surgeon present in the theatre 24/7, whether or not there was a consultant anaesthetist present 24/7, whether the trust is a university teaching hospital or affiliated, how much research activity, the volume of emergency bowel cancer operations per year, as well as the volume of all bowel cancer operations per year, and also whether or not there's inter-hospital transfer, which could be an indicator that they were sent to the wrong hospital in the first place. There's also things like surgeon specialty, surgeon grade, and volume and experience. And so those first 7 are trust level measures, and then the last 4, as you might have guessed, are surgeon level measures. So I just got a few colourful graphs to show you on those. So first up is the annual volume of emergency bowel cancer operations by region. So on the left here, we've got the trust level volume results, and on the right, we've got the surgeon level. So you can see on the left at the trust level, there's a lot of variation between different areas in the UK. And there's also quite a lot of variation in the surgeon level volume on the right as well. In terms of differences in access to specialist surgeons, again by region, for this quick talk today. So on the left is surgeon specialty. That is measured by whether or not they are a member of the Association of Colour Proctologists of Great Britain and Ireland. So there is a bit of a variation, but overall about half of the surgeons who are the responsible surgeon consultant for the surgery do have this membership. And then if you look on the right, surgeon experience, there's a lot less variation, and most surgeons do have more experience, which surgeons say is a good thing. So moving on to the second study, the breast cancer study that I'm working on currently, and it's in progress. So a little bit of background for this. There's a planned new breast cancer centre at St Bartholomew's Hospital, which I'm going to call BARTS for short. And motivation for this is that the breast cancer survival in BART's catchment area, being North East and in East London, is lower than the national average, and some areas are even below the London average. So there is a need to promote prevention, to promote screening, and also risk awareness and earlier symptomatic presentation. The catchment area has lots of multi-ethnic and socially disadvantaged communities, with variations in languages and health service engagement, and high rates of chronic disease and inequalities. For example, breast cancer screening in Tower Hamlets varies substantially by GP, and there is historically lower uptake in, for example, Pakistani and Bangladeshi populations. So the three key research aims of the study is to improve primary prevention of breast care, promote screening participation, and improve encouragement of help-seeking behaviour and onward referral for possible symptoms of breast cancer. So to achieve these aims, we are developing a multi-stage programme of research, stakeholder engagement, and evaluation to address these aims. So we're hoping to target breast cancer incidence and the overall local gap in breast cancer survival compared to national rates, as well as address community and inequalities involving communities so that we can appropriately tailor interventions to meet their needs. So the objectives of the current research, the first, there are like multiple stages. The first stage is a quantitative analysis of inequities along the breast cancer pathway, both between the BARTS catchment area and England as a whole, and also within the BARTS catchment area. To do this, I've been looking at publicly available data and also anonymised local data and census data, and I'll be able to share a little bit of that later on. We're also at the same time doing an evidence synthesis, looking at lots of literature reviews to try and identify previous interventions that have been shown to reduce breast cancer risk, increase screening participation, and promote earlier symptomatic presentation. And our focus is on what can help reduce inequalities. A third, also simultaneous stage, is involving communities, patients, general practitioners and commissioners to understand the local obstacles to earlier presentation and ways that we can improve the experience of care from the stakeholders' perspectives. So these three stages will help us to then design a study or multiple studies to evaluate the interventions identified from stages 1 to 3 to try and improve breast cancer outcomes and reduce inequalities. and also to design a mixed methods evaluation of the surface reconfiguration and transformation. So as I said, just going to show some preliminary results from the quantitative stage. So just some brief methods. Among other data, we've got some information on breast cancer screening from NHS England, the GPs practices covered by the Central and East London breast screening service. This has information on monthly coverage and uptake for each general practice. So by coverage, this is the number of women eligible for screening who have a test result recorded in the last 3 years. And the uptake is the proportion screened adequately within 6 months of invitation out of women who are invited for screening. For these results, each measure has been averaged over the 6-month period from May 2022 to October 2022. And the general practices have been ranked from highest to lowest, separately by mean coverage and mean uptake. And we were also able to retrieve practice profile data from Public Health England's fingertips resource for these general practices. So there's just a couple of graphs here. So the graph on the left is coverage, and the graph on the right is uptake. So the mean coverage ranged from around 60% to 72% for the GP practices with the highest coverage, whereas the lowest practices were all under 35%. And then the figure 2 on the right, the mean uptake for the highest practices ranged from 56% to 72%, and between 7% and 28% for the practices who were ranked lowest. And generally, the practices that were ranked highest by coverage or uptake, most of those were in Waltham Forest, whereas the ones who were lower were mainly in Newham, City and Hackney or Tower Hamlets. So that was a very brief tour through 2 projects that are investigating inequities for patients with cancer, but some lessons from both projects. So there is a need for rich sources of data and methods to obtain this data to assess gaps and potential areas for improvement. There is a need for a variety of methods. Over the last few years, I've used a lot of methods. I have more plans to use other methods, and these include record linkage, propensity score analysis, multiple imputation, risk prediction, rank analysis you've just seen on the previous slide, and we've got geographical analysis planned, and as I said, we're doing the evidence synthesis as well. It's really important that we consider all parts of the patient pathway. For the bowel cancer study, we are focused on patients who need emergency surgery and they're presenting with late-stage cancer, whereas in the breast cancer study, it's all about prevention and screening. And it's also really important to involve and engage patients and public, and those have been a big part of both projects. So just some quick acknowledgements with thanks to the NIHR ARC North Thames and also colleagues in London School of Hygiene and Tropical Medicine, Royal College of Surgeons of England, UCL and Queen Mary. And of course, big thanks to go to our representatives from the public and patient involvement panels. I know that was very quick. If anyone would like to talk more about anything I've mentioned today, I'm happy to talk. Otherwise, there is my email address. Thank you very much.
Thank you, Helen, for the amazing talk. We have a question online. I think we can start with that. I think the question refers on the first case study, but I think it can be extended to the second one as well. The question is there any effort to understand why the disparities exist between different regions of the UK? And on the second one, I guess it can extend to different regions of London.
Yes, so we've been doing the stats analysis to try and figure out if there are differences. And we're talking to surgeons and patients, surgeons who have the experience of different hospitals to try and find out. I will keep you posted. Still to be determined.
Thank you for that. Are there any? Yeah, sure.
I think this work is really important for all types of equities. This sort of following up from that previous question. Are you looking at all sort of the influence of politics? So I don't know. I'm going to put anything about colon cancer or breast cancer, but I'm currently working in lung cancer, and from my understanding, one big reason why mortality is higher in people lower socioeconomic status is that because they have on average higher BMI and higher smoking rates, surgeons are less willing to operate on that. And I'm wondering if maybe that's also part of why maybe less experience. Well, I get experience, they can see so much of that. So less expert surgeons are maybe more willing to operate on people, whereas more specialized surgeons are very conservative guidelines, as you said, that might be inaccurate.
Yeah.
I guess I'm asking for your thoughts on that.
Yeah. No, so we have been able to look at comorbidities. So in I mentioned we've done risk prediction for the bowel cancer study. So as part of that, I've included the Charlson score, which is a crude score of how many comorbidities patients have. There's actually another section of the project which is all about looking at multiple long-term conditions. So seeing if including those comorbidities in our risk prediction can help improve our prediction models. So yes, we are looking, yeah.
Yeah, super interesting. I'm based at the division of psychiatry at UCL and also department as well. And some of my work's looked at cancer linked to mental illness. And I just wondered if you're looking at clinical studies that we felt to do that. There's a lot of evidence in that population that they don't administer screening. They're usually situated in very deprived areas. They're much less likely to have emergency surgery. They're a very difficult group of patients with many long-term conditions and high risk, 61% of smoke in the UK, obesity, very few less. And so I always like to wait and then talk about when you can talk about long-term conditions. So yeah, like a really important group of community.
Yeah, I agree. It's important. We don't have plans to look at that specifically. However, in the multiple long-term conditions work I was talking about, that includes looking at all different diagnosis codes that are present, and some of them do relate to mental health and illness. So I hope that we're still able to capture that facet.
In the interest of time, I think it's time to move on to the next speaker.
Yeah, thank you.
Warm round of applause for Helen. While they're very important speaker, intro. Allow me to introduce our next speaker, who's David Shorthouse, lecturer in pharmaceutics at the School of Pharmacy, UCL. David we'll delve into the fascinating topic of uncovering inequalities in reported side effects of drug formulations. David?
Thank you. Yeah, so a bit of a wordy title. And I can see my slides of problem with Mac to PC, I guess. So I'm actually a group leader in the School of Pharmacy. And this is a kind of sort of outlier project for me, really, because most of my work is actually on material science and around machine learning of new formulations and new ways of delivering drugs for diseases. But I had a very talented master's student over the summer who, when I gave her a list of about 30 potential projects, she really honed in on the one that was around sex biases and inequalities in formulations and ran with it really, really well. So this is the work that she's done, and I'm really just presenting. So what we're concerned with, and I can hidden my
the person that more and there is an floating weighting controls.
Thank you. Great, I can read it. So so we're interested in this concept of what's called formulation. So the idea is that a drug is not the same as a medicine. So to go from a drug to a medicine, you need to formulate that drug. So we need to do something to the molecule. So the drug is often things like powder. What we might then do is you might then crush it into a tablet with some chalk, and then you can eat it, and you can have your drug. But actually, and now I've clicked off the presentation. There are many different ways you can formulate a drug. So obviously there are things like tablets, capsules, inhalers, injectables, whatever. There's a huge landscape of different ways you can formulate the same molecule. And so often in the clinic and in the pharmacy, you can get the same drug in different formulations. So here we have very American-centric, but ibuprofen. We have 3 different formulations of ibuprofen. So we have tablets, we have capsules on the left, and then we have what are called caplets in the middle, which are like a new, exciting way that you could deliver a drug. But what I'm saying here is that essentially you can get the same drug in different formulations at the same time. And there's this huge field of research that I have just joined. So I'm actually an oncologist by training, and I've moved into what's called pharmaceutical science. And there's this whole field of research around how do you deliver your drug and how do you manipulate your drug to improve or change its pharmaceutical properties. So you can stick it into particles, put it in little needles. You can develop inhalers to deliver the same drug in different ways. You can also chemically modify your drug to change its pharmaceutical properties. And that's what I'm going to talk about today. So this chemical modification of a drug to make it, in theory, better and more safe. So the type of modification that I'm mostly focused on here is what's called pegylation. So pegylation involves this molecule called PEG. So after I wrote the sentence, I realized this makes it sound disgusting, but it's not as bad as it sounds. So PEG is actually a organic molecule that is derived from petroleum. It's not plastic, but it is very, very commonly used in cosmetics and now in medicine as well as what's called an excipient. So it's a molecule that is not active. It doesn't have the effect of the drug, but it's included alongside the drug to change the drug's properties. So what we do with PEG is we basically stick it all over the drug. So if this is a protein-based drug, we coat that drug in PEG. And pegylating a drug changes its pharmaceutical properties quite significantly. So it makes it, for example, less able to be degraded by enzymes in the blood, makes it different size, so the kidney can't filter it as well, and it changes the solubility and a number of other things. But the idea is that this is supposed to make the drug better because it means that you can give a lower dose that is more stable, you can have less injections. It's supposed to be kind of an improvement to the drug. Ultimately, this is something that is becoming more and more common. And so right now there are 40 drugs you can get on the market, at least FDA approved, that are pegylated. The first one was approved 30 years ago for SCID. But one thing that you should maybe note here is quite interesting is that the COVID vaccines were pegylated. So the COVID vaccines were packaged into nanoparticles, and these nanoparticles had PEG added to the outside. So a vast majority of people in the world have had access to a pegylated drug very, very recently. So there's been quite a lot of work, and you can't read this table, but it doesn't really matter, around the safety of these drugs. So people have been interested in whether pegylation makes these drugs worse. So this is basically pharmacovigilance data. So people have collected adverse events reports from patients who have reported side effects to drugs, and they've compared pegylated and non-pegylated drugs at the same time, because we have a nice situation where some drugs like filgrastim, you can get a pegylated and non-pegylated form at the same time in the clinic, often being given by the same clinician to different patients. And so we can compare the adverse events of them and see if one of them is worse than the other, for example. And the current status of this is that pegylated drugs are not worse than non-pegylated on the whole. But no one has looked at things like sex biases in the side effects. And so if you look at this table, which you can't actually read, and there should be, a red box appearing, there is actually some quite strong differences in the reported sex, or in this case, the gender of people having side effects to these drugs. And if you do the stats on these, they are statistically significant. In this paper, they didn't do the stats, and that's how I got onto this. So what I did with Freya is we started looking into the side effect profiles of these drugs and seeing if there is a sex bias, essentially. So we went to this database called OpenVigil. So this is a pharmacovigilance database. This is my first time using this kind of data, so this might be super common. You may all be very, very aware of this, I don't know. But essentially, this is a database that combines side effect reports from either clinicians or manufacturers, from either the US or German pharmacovigilance systems. So if a patient presents in the clinic with side effects to a drug, the clinician is supposed to legally write up a small report and submit it to these databases so that we can record whether the drugs are bad, essentially. So we went into these databases and we looked for drugs that have a matched pegylated and non-pegylated form that are available in the clinic at the same time. That's not very many, so we found 12 that have both, but most of them have very little data because the pegylated form is so new, it's actually only been, it's only been around for less than a year, a lot of them. So we end up with a list of 9 drugs that we want to study. And I won't bore you with going through all of these drugs, but they are drugs for different conditions. So they're not all just oncology drugs. They're not all autoimmune drugs. They cover a wide range of different things. Filgrastim is probably the most commonly given one. It's used for neutropenia. So this is when your white blood cell levels crash after chemoradiotherapy, and it's used to try and recover your white blood cell count. So filgrastim is the one that I'm going to mostly talk about because it's the example that I think is possibly the most sort of relevant. So it's used in cancer patients, stimulates your white blood cells to grow. It reduces your vulnerability to infections, and it's also used in HIV. It's 20 years old and it is a WHO essential medicine, so it's quite important. It's given to many, many, many people across the world, but you can get it in 2 forms. You can get it as Neupogen, so unpegylated. You can get it as full filler, which is pegylated. Okay, and these are both given concurrently. I've got some pharmacists working in the group and they say that it seems to be completely random as to which one you get. Depends on the clinician. And we looked into these reports to see how we get any data on sex bias in side effect profiles. So we end up basically, we remove cases where it's potentially clinicians will report which drug they think is causing the side effects. So we take the ones where the clinician suspects filgrastim is the cause of a side effect. We then remove the sex-specific conditions. So if the patient has breast cancer, prostate cancer, ovarian cancer, something that is specific to that, to one sex, and then we basically have a database at the bottom where we have 70,000 cases for filgrastim where we know what sex the patient was and what drug they had. And we can find quite a strong difference in the reported sex of patients responding, patients reporting side effects. So there's about a 12% shift in the number of patients, in the proportion of women who have side effects to pegylated filgrastim compared to unpegylated. And we can dig into what these side effects are, and we can try and figure out what we think is going on here. And so this is our log odds. So we've got whether it's more biased towards females or males, and then we have a p-value. So funnily enough, males are more likely to die on this drug, apparently. This is true of filgrastim as well as pegfilgrastim. Males are just more likely to die when on these treatments. But we can see things here that start to maybe explain what's going on. And so things like bone pain. So with filgrastim, right, you're stimulating the production of white blood cells. Bone pain is a sign that the drug is being dosed too high. So you've got too many white blood cells, they're causing pressure and pain in the bones. With men, it's more things like cytokine storms, so almost like an immune reaction to the drug. But there is clearly some kind of bias in what's happening here. But this is not the only drug that has this bias. So here's 4 others where there's a quite significant bias. This one, if we rounded it, we could make it statistically significant. It's very, very not quite. But actually, if we look at all 9 drugs, we find that 5 of them have a significant bias, 4 of which are in favor of women having more side effects, essentially. So, oh yeah, and then we can also take all the patient samples, or sorry, samples. We can take all of the, you can tell I do a lot of work in genomics. We take all of these records and we just stack them all up and do a logistic regression to learn or to compare pegylated and non-pegylated adverse events reports. Sex is a significant descriptor of whether you're likely to have had a pegylated or non-pegylated drug, essentially. So this is about 500,000 adverse event reports. So what do we think is going on here? So there's 3 explanations that I can postulate to you, and maybe none of them are true. But one of which is that we're still confounded by sex conditions here, because this is obviously post hoc analysis on adverse event reports. So we could just be missing the fact that pegylated drugs are given mostly to women with breast cancer, but the reports don't record that. They just say that you're treating a cancer patient versus breast cancer or ovarian cancer. The other thing that's a bit worrying is that females are generally more likely to have an immune-related side effect to a drug anyway. But recent work has shown, so this is literally from a few months ago, in the German population, and in a random sample of 500 people, about 83% of them have antibodies against PEG. And that's because of the COVID vaccine, essentially, because so many people have had the COVID vaccine. And so that means that potentially we all have antibodies against PEG, and that means that you're more likely to have an immune reaction to the drug. This also doesn't bode very well for the future of pegylated drugs, because the more antibodies you have, the less likely the drug is to work, because you'll clear it from the body faster. So it's a little bit of a worry. But the third hypothesis, which I think is more interesting, is that the dosing is wrong. And the side effects support that more, the side effect profiles support that more. So dosing studies are pretty much always done on men, age 25 to 40 as well. And what we're going for with dosing is you're trying to hit this therapeutic window. So if we've got time and a drug dose, if you have too much drug, you get an adverse effect. If you have not enough drug, it doesn't do anything. You want to get the drug in this therapeutic window, the concentration. And so in most drug regimes, you end up being a bit like this, where you bounce around. And so you take a drug maybe once a day, you get a big hit, you try and avoid being in this adverse event window for as long as possible, for as short a time as possible, and stay in the therapeutic window. And the whole concept of pegylation is that you're supposed to be doing this. So you're trying to reduce the size of these peaks and troughs to fit in the therapeutic window better. The problem is, though, if you get this wrong, what could happen, I would hypothesize, is you can end up in this situation, where you have too high a dose and you get stuck in the adverse effect window for a longer period of time. And being in the window for a longer period of time is worse than being in there for a short period of time, but with a break. And so this could be an explanation as to why women are seeing more side effects to pegylated drugs. So that is the conclusion. So we can see a sex bias. Women are more likely to report adverse effects, or the proportion of women in these reports is higher. That's all we can say. And we have these 3 possible explanations. So I will finish there. Say thank you for your time. This is my current group. These are my MSCs. And so Freya is the one that did all this work. And she is this one in our 90s band album cover lab photo. So yeah, thank you for your time. Any questions?
Thank you for the amazing talk. There is a question online that I think we can start with that. The question is, why are dosing studies mostly carried out on men?
So, good question. I think, so one thing to kind of start off with is the fact that there is a difference between a sort of drug discovery clinical trial and a repurposing clinical trial. And so there is more strict criterion for a sort of discovery clinical trial where you have to include minority groups and women. Whereas for repurposing trials, they're still a little bit Wild West, and that you can kind of get away with just checking that it's safe and it doesn't kill people, because the drug is known, essentially. And so that means that I think there's less sort of interest in doing it properly. And I think, to be honest, I just think the pharma industry isn't as aware that there can be an inequality in reformulations, to be honest.
Thank you.
It's really, really interesting. Just a couple more sort of possible explanations for this discussion. It's everyone knows that clinicians are exposed to inequities, but they don't always get censored, and where they do get censored, it's more likely within a randomized trial context, so it's monitoring rankings that are really probably very careful. But we also know that women traditionally don't go into randomized trials. There's a huge disparity there in terms of men and women. So I wonder firstly if you had information on, is it through a trial setting, or are you capturing also the sort of clinical use of some of these? And then the other thing is within the general population, if you ignore treatments, if you look at reports of things like cognitive pain and some of those side effects that you're seeing more often than women, they generally are reported more often than women, regardless. And again, there's more like probably from a clinician reporting perspective, they may be more likely to attribute something, pain in a woman than anything in that. So how much of this is actually real, and how much of it is around?
So to answer your second question first, do it wrong way around. So on the the fact that women might just report different side effects. One thing that we are yet to do, because I haven't got around to it yet, is to look into comparing those side effect profiles to the pegylated and unpegylated form. So if I just quickly go back to the this volcano plot. So this is just for pegfilgrastim. We have the equivalent for filgrastim, and what we can then do is we can do a difference and see if there's a shift. Does bone pain become more present in the pegylated versus the unpegylated, for example, and that's to do, and that will, I hope, answer that question. The first question, we don't know where this data is coming from. It's not recorded. So as in it's not passed on to the users, but the FDA does record where it comes from, and they report that something like 95% of the data is from the clinic versus from trials. But we don't know whether we are getting a biased selection here, for example. But maybe we can have a chat afterwards.
I think we have for 2 more questions.
It's really interesting to hear your hypothesis about the reason, and quite sort of useful to have that against the data, and sometimes that's missing. So it's really nice to have that. Have you got a plan to test it? And I suppose my biggest question about the analysis was why drop out the gender-specific conditions? Why not just adjust for that? And also look at dosage in your next stage.
So in terms of the gender-specific conditions, we were worried that pegfilgrastim, for example, might be indicated for breast cancer, whereas filgrastim is not. We might end up biasing selection purely because, for some reason, pegfilgrastim might be the breast cancer treatment, and if you have bowel cancer, you have filgrastim, for example, and that would completely bias the sample. So that's why we removed the sex-specific conditions. Though I will note that actually something that was a little bit worrying is that we only remove, in this case, about 1,200 patients. So most of them are just listed as having cancer. So we don't know whether it is a sex-specific condition. In terms of testing it, I don't really know how we would do it other than doing a clinical trial and then actually taking samples and actually looking at levels of the blood. What we have done is we've approached the MHRA about this, because one thing that we do also see is we know what brand of drug they had, and we can see a difference between different brands. And so certain brands of drug have actually a bigger bias than others. And I won't name any names, but there is a certain company where a number of their drugs all induce a bigger sex shift. And so we suspect it's the way that they're adding the peg. They're possibly adding more, or they're using a different way. And so we're hoping to work with the MHRA to try and figure out whether we can just, probably the best case is getting a label on the box, which doesn't sound very much of an achievement, but that would be one thing that at least will hopefully raise awareness of it.
There was some good research on things like formulations. There seems to be like a big leap in this, like the patients or something that you mentioned. I just wonder if maybe you have some use of this. So if you're a pharmaceutical company, with the funding model is that you develop and then you recover loss to patents that last for months. And so actually the pharmaceutical company in that model that is very costly to develop new access. So some companies might go for a combination or a combination tablet or something like that. And then the regulatory said that has some advantage. That issue can be patent, and that so that in terms of health equity, so there could be in the observational part of this the data that we see on certain companies like tech could come from healthcare systems that are funded, or could be area that could also be prescriber biases around in certain areas of the country, maybe that prescribers are under more scrutiny, and so they go for the unpatents that's active rather than the new fancy formula. But we have some they're on here.
Yeah. So we do have, so we do know, so even though this is supposed to be US centric and German centric database, we do have the country at which the drug was prescribed, and we have quite a large range of countries, and we don't see a bias towards country. That doesn't mean there isn't one, because we're seeing a very Western view of what's going on. In terms of your question on the incentives of this, I didn't want to say much about this because I don't want to kind of sound like I'm really being aggressive against pharma companies. But yeah, there is a bit of an incentive to do this, because if you pegylate a drug, you can basically reissue the patent on it, and you can get control of that drug again and prevent it from becoming a generic. And so there is an incentive for pharma companies to do this to avoid losing control of their drug. So yeah, I think there is a problem there as well. Yeah, and I'll.
Everyone, let's give another round of applause. And next, I would like to introduce Rachel Burns. She's a research fellow at the Institute for Health and Economics. And today, Rachel will be talking about assessing healthcare and hospital admissions for 1.2 million of non-EU migrants and refugees in the UK, and sorry, in England. Wait, if I can get my up. And reminders, you can use a QR code and ask your questions on the slide.
Great, thanks. Does anyone want to stand up? Right, it's been 30 minutes. Let me stand up for a second. Yeah, stand up. Just move a little bit. Yeah, okay, I've got one. That's how I was feeling. Oh, and I'm on mute. Well, good. Yeah, get a little stretch in. Everyone online too. Thank you. Great. Thanks so much for having me today. I am Rachel Burns, and I'm at the Center of Public Health Data Science, Institute of Health Informatics. And today I'm going to be speaking about healthcare and hospital admissions of adult non-EU migrants and refugees in England. So migrants' use of hospitals. So kind of evidence around Europe and England is quite limited and very mixed. So within Europe, more broadly, there's been a number of systematic reviews that have been done that have said that migrants tend to overuse emergency accidents and emergency departments and underuse things such as outpatient appointments. But in England, there's probably around 4 or 5 studies, of which show a pretty kind of mixed picture. So one of the reasons that this is quite a challenging thing to study is that migration status is not routinely collected in most administrative health records. So things, and we know things such as like hospital use can be really important to understanding, what people are going for. Is there an issue with actually accessing preventative care? Are there other health inequities that we're actually seeing? So these kind of 4 or 5 studies that have been done in England, a number of them have used proxies to study migration status. So that could be ethnicity, for example. They could be, for example, there was a data linkage study that looked at registering with a GP for the first time after the age of 15.
to kind of try to estimate, are they an international migrant? That particular study found half the amount of admissions for that at 15, that kind of later stage registration group compared to the general population. But a lot of these studies happen to be small sample sizes. So in the emergency department in some hospital, they go around and chat to people. Or they're self-reported healthcare usage. And of course, going to the hospital might be something that you do remember, but actually how long you were there, what you were there for, as time goes on, we tend to forget those things. So data linkage really offers a quite exciting and innovative way of actually kind of looking at the relationship of migration and health. But how do we actually identify migrants? So our kind of definition within this study is a migrant is someone who's been born abroad, born outside of England. So here I've got two kind of pre-migration screening data sets. So one is the non-EU tuberculosis screening data set. So these are individuals who are coming to the UK and are applying for a visa, coming for more than 6 months, that have to get a TB chest X-ray as part of their visa. So this program is developed and led by the International Organization for Migration, and they work with the Home Office and what was PHE, but now UKHSA here in England. And so in total, over kind of 15 years, we have about 1.8 million non-EU migrants. The second data set here is the Refugee Health Check data set. So this is refugees who've been granted asylum abroad. So they've gone through a resettlement scheme and they get a health check prior to arrival to the UK. So that the idea is that to help with integration into their local health context. And so together, these two data sets are what we've called the million migrant cohort here, which is around 1.8 million individuals. So I did a 2 linkage step. So this was a deterministic linkage, and that was due to which deterministic is versus kind of other methods such as probabilistic is matching based on various personal identifiers. The reason we had to do that in this first instance, I was really limited to the architecture of the data. I literally could not manipulate it very much in the way in which I could access it. So in that first step, coming from the 1.8 million, we had around 1.1 million individuals that linked, so around 63%. So to kind of put into reference a study that was published in 2011, did a similar thing looking at individuals who are getting screened upon arrival for TB and linked them to PDS, which I forgot to say is the Personal Demographic Service. It's kind of like the NHS backbone, holds your NHS number, where you are, like where your GP is, etc., but also has names, date of birth, sex, which these data sets also have. So the study that was done in 2011 only had 30% linkage. So there's a few reasons why this might not be 100%. One, someone might have never actually arrived in England. They might have got their visa, but actually for some financial reasons, other reasons might not have come. Two, maybe they came to England, they actually didn't engage with the health service. They never went to the GP, never went to the hospital, so they wouldn't have an NHS number. They wouldn't be within this data set. From 2015, with the inclusion and start of the NHS immigration health surcharge, which some of you might have had the privilege of paying, an individual's name is now they're automatically given an NHS number after they pay that charge. So actually from 2015, the coverage goes up to around 80–85%. So quite a lot better in that case. But still in those earlier years, is not being in this data set mean no healthcare utilization? And then it's quite harder as the years go on to actually say that, because someone might have an NHS number, but still never actually gone to the health, engaged with the health system. So another reason is they might have gone to Scotland, Northern Ireland, or Wales. And as well, they could have, it could just be linkage error, that we've misrecorded, an individual's name from their immigration data set to when they showed up at the receptionist in York and gave whichever name they, gave a name and it was incorrectly recorded. So from this, I did a linkage, an 8-step linkage methodology that is used by NHS Digital as well. And this is linking to HES. So the 25% is out of the total cohort, but actually the linkage was, and the data we ended up using as individuals, because we didn't have names in that linkage step, we had to use NHS numbers. So if you kind of take it out of this, it actually goes into 40%. And of course, we would never expect 100, right? This is a really young cohort. People come to England and might never use the hospital. So who is our comparison cohort? So we decided to use all individuals, all adult individuals 18 to 75 who had a hospital admission in our study period, which from 2007 to 2020. So how we ended up estimating the denominator was, we now know people who've gone to the hospital who didn't come to the hospital. So we estimated our denominator from ONS census estimates for England by age group and by sex. So our study design, so it was a longitudinal study cohort that we broke up into 3 time periods. And this is mostly due to anyone who works in HES, there's temporal changes in the kind of data quality to try to kind of, better estimate our outcomes. So we looked at a number of different outcomes. First, all-cause admissions, planned admissions, emergency admissions. We did rates and rate ratios, comparing the million migrant cohort to the general population of England, and then maternity hospital admissions. And we had 2 exposures that we were looking at. So this data had information on the entry visa type. So for example, work, working holiday, the refugee cohort, family reunion, settlement, dependent, and student, and then region of origin. And the reason, so this is a descriptive study, we didn't end up including those 2 exposures together in a model, just because, for example, our refugee cohort, around 87% of them are from the Middle East. And so, or from MENA, Middle East and North Africa. So it kind of the collinearity between them was too much. So we separated them out just to kind of give descriptive numbers of what's going on. So the tricky part about this, and what comes into migration, if anyone works in migration, is that we had no data on, make sure I'm on time. No data on when people leave. We have an idea of when they arrived, but we have no idea, did they actually arrive? How long did they stay? Did they overstay their visa? Did they switch visas? So all of this had to be taken into account because we wanted to look at, kind of estimate an end date to look at that length of time at risk for a hospital admission. So we did use multiple imputation using linear interpretation to estimate the cohort exit date and account for that uncertainty. So how did we do this? So in that kind of middle category there, so the UK Home Office actually does give out data numbers of entry clearance visa categories. So they'll have things such as a total category, study and work, pretty much those are the kind of main ones that they include. So we took our million migrant in that kind of left category. These are the visa categories we had, and I matched them. So for example, people in family reunion, I included it in the total. And also I assumed that someone was coming on a family reunion visa, that they'd stay for the entire length of the analysis. The same for settlement dependent, they've come to settle here, or coming on a dependent visa, again, assumed the stay for the entire analysis. So students, working holiday, other and unknown, had to think about how we impute that exit date. So, no, actually, so how did we do that? So what we did is we looked, so each visa category comes with estimates of numbers for the length of time. So someone who came, the number of students that came for 6 months, the number of students that came for a year, 2 years, 3 years. And we looked at the cumulative probabilities. And then through giving each migrant a random number, seeing with the same visa status, see where they would have fallen to estimate how long they would have been in the country. That makes sense. We can get into that more later. So for example, to kind of see it with a picture. So the England cohort all entered in 2007 and left at 2011. So that was, they had kind of the equal time at risk. So an individual who entered once on a more permanent visa, so here in blue, so refugee, settlement, and family visas, entered whenever they entered their entered date, and then stayed for the duration of the cohort. Gets a little bit trickier because you obviously have people who enter once, enter twice, enter 10 times, and how you play around with how kind of their time at risk they are. So for example, if someone just entered once on a study, work, or other visa, the exit date was based on that imputed date value. For example, I had a different one, they had a second entry, or had a second entry on a more permanent visa. Sorry guys, you can see on the E one here, or F, they had time in between. So a lot of different things we had to kind of think about. So what was the statistical analysis we did? So we used 10 imputed data sets that were then analyzed, and I pooled together the estimates using Rubin's rule to account for the uncertainty in imputed information. Used negative binomial regression models with each exposure, so either visa type or region of origin with each outcome, with person time as the offset, and then used robust standard errors to cluster at the individual level to account for people who entered more than once. So we looked at marginal incident rates and sex-stratified age-adjusted incidence rate ratios of possible admissions for the two exposures. We had a number of sensitivity analyses. So the issue with like which denominator we use, so just those with NHS numbers or the entire group. Dealing with individuals, around 10% of migrants go to one of the developed nations. How does that impact this? In the imputed length of stay, kind of playing around with that, as well as people came into our cohort might have already lived in England, for example, so we might have missed admission. So how do we deal with the excluded admissions as a result of the imputation? So what were our results? So, oh God, I've gotta run through this, baby. Okay, so we had around 200,000 adult migrants in the first cohort, kind of 210 adult migrants in the second, and that goes up quite a lot for almost 600,000 in that last cohort. This is a really young cohort, which we kind of imagine. This is a lot of people who are coming on student visas as well as settlement dependent visas from South Asia, East Asia, and Sub-Saharan Africa. 70% are 18 to 30 compared to 23% of the England cohort. So something to really, really think about here. So these are kind of high level, and I also realize horrible small graph. But so what kind of came out was individuals on more temporary visas, and this is actually the same for our various sensitivity analyses that we did. And from East Asia and Latin America had the lowest hospital admissions, had lower hospital admissions than England, as well as those on more permanent visas. More permanent visas, such as refugees, people on settlement and dependent visas, and family reunion visas, had equal or higher. So in the green here, you can see these are the countries that I just listed. So East Asia, and that first one in Latin America, and then people on student, working holiday, lower as well. We had higher men from the Middle East, and also men who are refugees had higher planned admissions, almost 2 times higher. And then female women on family and family and refugee visas had higher emergencies. And then lastly, another major finding was women on family reunion and settlement dependent visas, and women from South Asia and Sub-Saharan Africa had higher maternity admissions compared to England. So this is kind of, again, this finding, which will be really, none of this is published yet, I've just kind of finished this analysis, is going to be, we know 1 in 3 children born in England is to an individual who is a migrant. So it's kind of really, we'll have to really think about how does equity play into this, looking at potentially emergency C-sections. We know that interpreters aren't often available during these times. So kind of this is just showing us kind of a glimpse into kind of further analyses. So some of the higher maternity rates are up to 3 times higher. So this is to kind of conclude, this is the first national UK-based study to look at these, by visa type and region of origin, have an actual kind of entry date to kind of play around with. What's really kind of the take-home message is actually that migrants are healthy, as we know. They're using the hospital a lot less, and that kind of goes against the narrative that we see in the media. But are those lower admissions a genuine reflection of healthcare needs? This is a young cohort, so maybe. But for older cohorts, which we'll kind of look at more specifically, are we actually seeing barriers to healthcare access? Some of our cohorts that might have overstayed their visas because of healthcare charging, are they scared to be, going and accessing healthcare when they need it? So future research, kind of thinking of the stat side, we really need to think about kind of refining our imputation methods and linkage methods as well. Thank you to my collaborators and to the UK government, and welcome Trust. Thank you so much.
Thank you so much. So we have a question online for you. Just as a reminder from now on, if all speakers could repeat the question for the people online, just a quick summary of what we asked. So here they ask, talking about trust, how do you ensure migrants are not scared of negative repercussions to their visa arrangement? I guess that links from what you could provide in the discussion.
Yeah, great question. So how do you, I guess, trust with I'm going to bring this into a data context, really. So this data, getting kind of this data is, I've done it within my kind of contract with the UK government, which was PHE, and I'm really aware of the high sensitivity of this data. And so we work with a team, I mean, kind of making sure that you're actively doing work to engage with these groups. So we, in another role that I have, kind of actively have PPE and have co-investigators that are people who actually, not just migrants, but people who've been excluded from healthcare. So whether they've had charging from a maternity admission, or not been able to register with a GP. So it's such an important thing. Data is really powerful, and we're talking about that in this kind of whole entire presentation kind of day, is how do we make sure you're building trust with groups that have been, in the UK specifically, I'm not sure how many people know, there was a understanding of data sharing between the Home Office and the NHS, and that has done decades of damage for individuals to feel like they can go to the health system. So that requires, good information about, there should be a firewall between the NHS and immigration enforcement, and that's something that, tons of policymakers and UN organizations also kind of fight for. Yeah, great questions. I'll repeat them here. So the first question was, when with the categories, visa type can tell you some things, but it's not actually telling us a lot of other things, like why different reasons in which an individual might have migrated. And yeah, totally. And I think if you end up working in this space a little bit, even having something different, even having something more than just migrant is already quite exciting to kind of have an idea that a student has probably come here to study, but they've come to study, there could be many reasons why they came to study. So totally, that would be like amazing to have that kind of understanding. And it's really interesting thinking kind of statistically, like, what does visa type represent, right? When I'm thinking about, not in this study, but we did a COVID vaccination one, like, what is it? Because visa, requirements now it's a lot more expensive to study, but we also know that people's families take out loans. So it's not just necessarily an indicator. It could be an indicator of some socioeconomic status, but it's, that can really depend on region, on origin. So there's things such, as socioeconomic status in there, there's an education level for certain work, but it's not totally that if you have a work visa, you are like this. It's really, so it's that, doing further linkage studies to kind of further types of data would be really helpful to kind of understand, okay, if you have a person on a work visa from South Asia, that can mean so many different things. So I guess this is kind of a first instance of what we, a bit better data, but with anything, we kind of need more and more. And secondly, about understanding your NHS entitlement, totally. What's interesting here is with secondary care, so these are individuals who all have entitlement to care when they arrive on that visa. We're not sure how many of them overstay. We know most people who do overstay their visas and become undocumented arrive on a visa. So it could be that actually people end up losing that right and then not end up going to the hospital. So yeah, understanding entitlement, understanding that you can register, anyone, no matter who you are, can register with a GP in England is not totally, totally understand. You could show up at any receptionist and they wouldn't necessarily register you depending on, they might ask you for your ID and you might not have it. So it's a huge thing is this work cannot be done without co-production, qualitative methods, mixed methods. It's one piece of such a complex picture. Thanks.
Thank you. Okay, I think we have time for one question.
You mentioned that your cohort finished at age 75, I think, and kind of acknowledged it's a young group. I just wondered whether to sort of fill in the missing part of the puzzle, you could use death certificate because they have country of birth, and whether that would give you enough to kind of look at that older cohort, particularly given that we know that health care usage goes up in those 8 years.
Yeah, great questions. The question was that my cohort ends at 75 and potentially linking to death records. So we actually have, I've done the linkage, but didn't include it with this, from the HES ONS. So we have access within the ethics that we have currently to link to people who've been to the hospital and then died, which obviously is going to miss people who've just arrived and died. And we do have data on people over the age of 75 and children. We just felt like for this study, and also using the whole England population, I mean, my models were running for 70 hours and I was having to do 210 imputate it. And there's 2 people that can go on the UK to say special superpower computer. And I was they were like getting very angry at me. And so I restricted it basically kind of for computational things. And because over 75 and under 18, they have quite different use of the hospital anyways, was kind of our scientific rationale. But totally, I mean, hopefully additional linkages can be made because there's a lot that we can do with this. Thanks.
Thank you, Rachel. Really interesting.
Thank you.
For another round of talks. Then for the last but certainly not least, I'd like to introduce Bunting, a researcher at the Great Wall Institute of Child Health. So Catherine today will be sharing her work on evaluating the impacts of health visiting on child and maternal health outcomes, a pilot trial approach using administrative data.
Hey, hi everybody. I'm Catherine Bunting. I'm from the Institute of Child Health, and I'm going to talk today about a project that we are working on. It's for the Department of Health, but funded through NIHR. And the project is a mixed method study to evaluate the impact of the health visiting service in England. And we're kind of partway through this study, so I'm not going to be sharing any results today. Instead, I'm going to be talking you through how we are designing the quantitative part of the study using a target trial approach. So just a quick explanation of what health visiting is. If you live in England and you have a baby, then the health visitor is the person who can provide some support to you and your family in the first weeks and months of your baby's life. So the health visitor will come and see you, and that's often in your own home. And the health visitor really does 2 things. One, the health visitor makes sure that your baby's doing okay, so carries out health and development reviews. And also the health visitor can give you some advice and support as parents. And I think it's an interesting service from the perspective of health equity because it's an example of what's called a proportionate universal service. So there's a universal part of the service, which takes the form of what are called mandated contacts. And there are 5 mandated contacts that every family in England should be offered. There's one during pregnancy. There's a really important one a week or 2 after the baby is born, which is called the new birth visit or the new baby review. And then there are mandated contacts at 6 to 8 weeks and 1 year and 2 to 2.5 years. So there are these 5 mandated contacts that should be offered to every family in England, and that's the kind of bare minimum, the bare minimum of the health visiting service. And then there's a proportionate part to the service because health visiting teams have some flexibility to offer a bit of additional support to families based on the needs of the family. And so that can take lots of different forms, but it might be the health visitor coming to see the family more often to help with specific problems like feeding or sleeping, or maybe to support parents with their mental health. So it is a universal service. It's offered by every local authority, provided by every local authority in England, but we don't have a lot of information at the moment about what effect health visiting has on the outcomes of health outcomes of children and indeed their parents. So this is the question that we are trying to grapple with, and what we're really interested in is what is the effect of these additional contacts kind of over and above the basic universal service. So for families with a kind of similar level of underlying need, does this additional support help to reduce the outcome that we're interested in here, which is hospital attendance for reasons to do with adversity? So for the children themselves, That's going to be hospital attendances for accidents, injuries, attendances with maltreatment indicators. And then we can also look at mothers' maternal hospital admissions for reasons to do with mental health or other indicators of adversity like domestic violence. And we've got two sources of data to help us with this question. The data on health visiting comes from something called the Community Services data set, which has over 4 years, it has data on health visiting contacts received by just under 2.5 million children, and some information about basic information about what the contact was and how long it lasted and so on. But just to say, we work with a much smaller sample than that because the quality of the data in the community services data set is quite patchy, and so we have to do quite a lot of work to make sure we're working with data from local authorities that we can see have reasonably complete data. And that's a whole other presentation in itself, so I won't say any more about that now. And the outcomes data, we're using a great data source called eChild, which provides linked data from hospitals and from schools and from children's social care in England. So it's give you an example of what the data looks like. We've got 7 different children here, and we're showing their kind of timelines for the first 12 months of life. So from birth, and looking at the trajectory for the first 12 months. And the crosses here are the mandated health visiting contacts. The circles are these additional contacts that happen over and above the universal service. And the red crosses are the outcomes that we're interested in, the hospital attendances. So you can see here that child A here is a child who's just received the universal service. So child A is someone who's received 3 mandated contacts in the first 12 months of life and nothing more. And then you've got, by contrast, child G is a child who had this, the new birth visit, so an early mandated contact. None of the other mandated contacts, but did have some clusters of these additional contacts at different times. And both of those patterns, quite typical, quite common. So you can see some of the problems that we have in terms of design. These additional contacts don't really constitute a well-defined treatment because the timing of the contacts and how many you have, that can really vary quite a lot from family to family. You've got the problem, of course, that the outcome that we're interested in, the hospital attendances, is happening alongside the treatment. So we've got to give some quite careful thought to the temporal relationship between the exposure and the outcome. And then, of course, we have the really big problem, which is that these additional contacts are provided on the basis of family need. And as you might imagine, families with more complex needs tend to see the health visitor more often. They're also the families who you would expect to have worse health outcomes. So we've got a big problem with confounding by indication. So there are some different ways that you could set this study up. You could look at health visiting exposure in the first 6 months and outcomes in the second 6 months. You could treat health visiting as a time-varying exposure, but the approach that we have gone for is to try to set our study up as though it were a randomized controlled trial. And this approach is known as target trial emulation. It's becoming quite well established now. There's quite a lot of papers you can have a look at that will take you through the principles of target trial emulation. But essentially, there are 2 parts to the process. You start by trying to imagine the trial that you would carry out if the resources were available to you and there weren't any kind of ethical considerations. What's this hypothetical trial that you would ideally carry out? And you write the protocol for that trial, and then you see how closely you take each component of the protocol, and you can see how closely you can emulate it using the observational data that's available to you. And it's quite a useful approach for a number of reasons. The really helpful thing it does is it makes you think very carefully about how you define time zero, because in if you were running a real trial, you would determine which families were eligible, you would recruit your families, you would randomly assign your treatment, and you would start the follow-up, and those things would happen almost simultaneously in a lot of trials. So it really makes you think about how do we try to align those events as closely as possible in our observational data. The other thing that's nice about it is that if you have this situation that we have where this kind of the treatment can begin at different ages, at different times, you have the option to set this up as the sequence of trials, and I'll show you what that looks like in a moment. So this is the protocol we've written for our hypothetical trial, the trial that we would want to carry out if we could. So we thought that if we were carrying out this trial in the real world, we would try to recruit families. We would want to recruit families at the new birth visit. So the first mandated contact that happens shortly after birth. At that point, we would want to exclude any children who'd had any kind of hospital attendance between delivery and the new birth visit, including any neonatal care. So at that point, after determining whether your children are eligible and recruiting people to the trial, in the hypothetical world, we would randomly assign families to either the standard health visiting, the kind of control treatment, where the families would just receive the mandated contacts only, or we would randomly assign families to the enhanced health visiting service, where they would certainly receive the standard care, but also a program of additional contacts based on the needs of the family. And we'd start our follow-up at the new birth visit, and that would continue for 11 months. We'd be able to, in our hypothetical trial, then to have a look at we'd look at the rate of hospital attendances in the two groups and compare those rates. I think the key point to say here is that from a policy perspective, what we're really interested in here is estimating the intention to treat effect. So what the Department of Health, we think we want to know is, well, what's the effect of making this service available to a population, regardless of whether or not they then choose to take up that service or participate in it? What's the effect of making this service available? So I'll take you through how we emulate this target trial, and just to make it kind of easy to see on the diagram, I've assumed that all of our children who we looked at before, let's assume they all have the new birth visit on the same day, because it makes the diagram a little bit easier to follow. So the first thing we do is set time 0 to be the date of the new birth visit and the end of the follow-up 11 months later. And the key thing we have to do to make this work is to introduce the idea of a 1-month grace period. And we say that if you are a family, a child who has an additional contact with the health visitor between the new birth visit and 1 month later, we say that that child has initiated the enhanced health visiting service, and that's children E, F, and G here. And if you don't see the health visitor for an additional contact within 1 month of the new birth visit, we say that you haven't initiated the enhanced health visiting service, and that's children A to D here. And it's that comparison of the initiators versus the non-initiators that gets you as close as you can to the intention to treat effect. And that's what you see here, because child C does go on to have these additional contacts with the health visitor, but they start after the grace period. So for the purposes of the first trial, we say that they're untreated. We've got an interesting problem with outcomes that occur within the grace period, because you've got to work out what to do with those. What you can't do is kind of retrospectively assign those outcomes to the treatment groups, because you're using then kind of information that's only available to you at 1 month when you're clear about what the treatment was. You can't use that information to then kind of retrospectively say, well, this was an untreated outcome and that was a treated outcome. So we've got to give some thought to what to do with those, which we'll come back to. And then the final point here is that children A, B, and C, they up to the 1 month after the new birth visit, they haven't had any additional contacts with the health visitor. They haven't had the outcome that we're interested in. And so you can put these children forward into a second trial. And that's what the second trial looks like. So you move time 0 forward by a month. You look at who initiates the additional health visiting contacts between 1 month and 2 months. And then you follow up from time 0 now, which is 1 month after the new birth visit. And you can replicate that across the time period and set up this sequence of target trials, which is quite nice, because what you end up estimating then is the effect of initiating this service, the enhanced service, at different stages over the first 12 months of life. Then just a few words on the statistical analysis. Obviously, for each trial, then in the sequence, we want to make sure that the treatment groups are as similar as possible in terms of the underlying needs of the families. And we have a range of covariates that are measured at birth, some to do with the child and some to do with the mother's educational and health history and previous experience of social care. And we're thinking of using some kind of propensity score method to match or weight the treatment groups. We also need to deal with these outcomes that occur in the grace period, and our proposal, because it's probably the simplest thing to do, is to randomly allocate those hospital attendances to either one of the treatment groups. Then we can, for each of our what ends up being 10 trials, we can estimate the rate difference. So the difference in the rate of hospital attendances between the children who've initiated the enhanced service in that month and those who haven't. And then we can, hopefully we'll be able to see, does the effect of this enhanced health visiting service, does the effect vary depending on how old the child is at the time when you start those additional contacts. And if it looks fairly constant over time, then you also have this option to pool the trials and calculate an overall effect estimate, which is going to improve the statistical efficiency of the estimate. So that's as far as we've got, and we've got the design and we've got the data, and we're going to start work on the analysis now and see how that goes. But just a few reflections on this method, because there are different ways of setting up a study like this, but we quite like the target trial framework, partly because it helps you, it gives you this kind of structured way of thinking about the design. Make sure that you're quite transparent about why you've set things up the way you have. Helps you avoid making some kind of design errors, particularly around the sort of temporal relationship. But I think particularly the most important thing really is that it makes sure that you're answering a question that's useful and relevant to policymakers. And it's something, we're evaluating the effect of something that's got that real world meaning and can be understood easily by policymakers. So we like the approach, but despite that, it doesn't matter how good the target trial emulation is, it can't compensate for what you might be missing in the data. And in particular, we've got problems with the kind of misclassification of health visiting contacts and missing data there. And also not all of the covariates that we would really want to have to do a good job of dealing with the confounding. So we think this probably gives us the best possible approach to do something that's going to be useful for the Department of Health, but also longer term, would like to think about linking our administrative data, perhaps for some cohort studies, to improve our range of outcomes we can measure, and possibly also do some primary data collection and ideally work with some local authorities to use some randomized designs for evaluating some new models of service delivery.
Very much. You are really interesting. Unfortunately, we only have time for about one question for. I'm sure everyone wants to get to lunch, but is anyone burning to ask a question?
Hi. I thought that was super interesting and just a really detailed and neat way of addressing the problem. I was interested in whether you have any information as to why parents receive the enhanced service. Because I wonder whether there is some variability there. I have children and it's a long time since I had contact with health visitors. But sat when my daughter broke her leg at 9 months, we were on the enhanced service, and that was the only reason. And so I am probably not like a lot of people that have enhanced service and enhanced contact. I just wondered if whether you can stratify why they might
Sorry, please, you can repeat the question.
Oh yes, sorry. So the question was really about whether you can see whether we have any information about the factors that have led to a family either being offered the additional contact, the enhanced service, and indeed taking those, deciding to take those contacts up. No, and that's probably the biggest limitation of the data that's available to us. So it's partly the health visitor will do a range of things. So sometimes the health visitor is providing some support for families that are struggling generally, maybe because of all sorts of things that are happening in the family or in the environment. And some of those things you can get a sense of by controlling for, index of multiple deprivation in terms of mother's educational background. We can look at the mother's history of kind of mental health admissions prior to birth. We can look at her previous experience with social care, indicators of domestic violence, general sort of contextual problems that the family might be grappling with. We can control for those sorts of things. What we can't do, control for exactly your example, which is a kind of shock event, an accident, a particular problem with breastfeeding, something that happens after birth, and that immediately prompts the additional contacts from the health visiting service. This is the best, the closest we can get, and that would be great if the data I just had somewhere, if with the health visitor had somewhere, what's the trigger for this contact. We don't have it, so we do the best we can.
As good as you can get.
Yeah. Yeah.
Okay, thank you so much. And again, I'd like to thank all four of our people today for highlighting some of the excellent work they're doing. Okay.
Thank you, Vanessa. That's great to help. It's not too bad. We'll reconvene in 45 minutes or so, but 10 to. There is lunch downstairs in the South Voices. We better get that quick because Leandra's been saving off all the hungry students. So back in 45 minutes. Yeah. Thank you. Okay. You done much work on targets emulation before?
No, and in fact, no, not at all. I'm completely new to
recording, and we'll have two sessions this afternoon. Starting off with this workshop, which I'm very excited about, from Borda and Antonella Perini at the Turing, and then our second afternoon session will be a panel session on translating data science research into equitable health policy. I'm going to pass over to Leandra to introduce this current session.
Thank you. Just a very, very quick intro. I'm also very excited for this session. This is really what I want to hear some introduction of this. But we have the Borda here. They're amazing experts from the Turing Institute, and they actually
Have just recently published a whole set of workbooks on health AI safety. So there's a lot to learn from the sectors, and we have an interactive session with them. So I think Antonella will tell you a bit more about how to get interactive in just a minute, but I hope you enjoy it too.
Yes. Well, hi everyone. It's great to be here. So I'm Antonella. This is Anne. So maybe to tell you a bit about the structure of the workshop. First, we're going to introduce some key concepts that we're going to use throughout the session. And then we're going to identify and give a bit of a framework to understand entry points of inequity in AI systems in the health sector. And finally, we're going to give an overview of some ethical principles that can guide responsible innovation. And as Leonard said, the idea is to have this as a very interactive session. We're going to use Mentimeter, but at the same time, we're happy also for you to raise your hand if you want to comment things or bring some of your experiences or examples to this session. So let's kickstart the session with our first question.
Yes, we did the introduction, sorry. I'm going to use this very clever system here of tabbing through to Mentimeter. And we would welcome your thoughts about, and you'll have had conversations like this, we're sure today, about factors that influence your health. We're looking about your perspectives. And you have opportunity to use Mentimeter to just put a couple of words in. And we'll give it about a minute.
So hopefully everyone can read the code just in case. It's, well, we go to menti.com and then the code is 11984957.
And if anybody's online, I hope you can join us, but if you are having difficulties, you can put your answers into chat. Sorry? So if you go to menti.com, menti.com.
MENTI.
Sorry, can you see that? Yeah, and then you just put in that code. Sorry, we didn't say more about that. And we will do the reveal in a minute. Any final words, please feel free to do that in the next couple of seconds. Okay, I think we may have enough here to work with. So let me see if that works.
You're going to 50%. Yeah. And then H.
Oh. So as you can see, we have a wonderful word cloud, and we can see that there are a number of things that have been emphasized here about lifestyle and diet and exercise and environment. So we're looking at physical things, medical things, environmental things like seasons, winter, and medical things like infections, but also social factors like gender and access to services. So this is a very good just snapshot of everyday sort of factors that can influence us in our everyday health matters, and also family history, which is a good one when we're thinking about genetic disposition, for instance. So I don't know, Anton, if you have anything further you'd like to add here, but I think this is a really good sort of positionality exercise as well about who we are and what might be very individual factors that influence our health. So if we go to back to the introduction here, and we go next to our next slide. So we have the classic social determinants of health, which is really what influences health equity.
Yes, and I think part of the responses that you wrote, some of them, fall into these constitutional features that are somewhat fixed and that influence our potential, but at the same time, you also wrote many of these other things that are exemplified here in this figure by Delbert and Whitehead, which talks a lot about other features that influence our health potential and that are social minority and that can be somewhat quantifiable. So the first layer, for instance, there are factors related to our lifestyle. You mentioned exercise, smoking, those kind of things that influence or can influence our health potential. There were things related to community or social relationships, networks, for instance, supporting our neighborhoods, community support and so on, that kind of so having a way to impact our health. And at the same time, other conditions related to work, life, you mentioned education, you mentioned housing conditions and other things, and then conditions related to socio-economic, cultural, and environmental aspects. And in a way, part of the area that covered from this second layer to the autonomous layer is also that area of policy intervention, structural intervention that can also influence or affect our health potential. So this is one of the key terms that we have been using when a lot of this research that we've been doing on health equity in AI systems. And then the other one is health equity, and it's part of the title of the session. And going back to our Mentimeter kind of tool to propel interaction, we have yet another question on what do you think or what do you understand by health equity, what health equity needs to do. So we're going to maybe give a minute for this one. Yeah.
These are open-ended questions. I'm sorry, I don't have my mic on. So this is an open-ended question, and we'd like you to just put a couple of words in, and drawing also from your symposium today as well. And this is to really act a little bit like maybe a refresher as well, but also personalize it where you can. Okay, thank you. I think we've got some good responses, so we'll just reveal them now. And it's interesting that we've got similar things that also ties back to factors which influence our health, like good access to healthcare, and the idea of healthcare being in the most equitable sense, looking at disadvantage and working around the disadvantages of access to healthcare, and having this equitable lens across health for the population. I'm just saying, I'm sorry, I'm not familiar with this screen, but I think we can go further down, and more about equal access. So that seems to be coming up a lot. And I think that's a really important equitable lens here. And I think what we're going to do when we're looking at some of our other interactions is also how we can look at equity across different levels of spheres of influence. So one item here about being a data scientist is interesting, about giving accurate predictions, for instance, and how accuracy can somehow ameliorate some sort of risks that we're providing a decision, a risk, an accurate prediction, which ameliorates risk of not being accurate. And I think we've got some very thoughtful expressions here. I don't know, Anto, if you'd like to say anything more about that, both at the individual and the system level.
Yeah, this is very interesting, and maybe jumping into some of the other slides that we have, but like there are some kind of expressions that relate very much to this notion of social justice, and like some of you maybe did not put that into your own definition of health equity, but it is quite embedded in those answers. But yeah, in general, like the literature has of course defined health equity in different ways, but the ideal of a society where everyone can achieve and experience their full health potential is one of the main key that defines equity, which has been expressed already in the answers that we have here. And maybe if we go to the presentation, but in all cases there's also this idea of social justice included in the definition. And
sorry.
Yeah. And in a way that, again, as many of you highlighted, this sense or kind of commitment to addressing those differences in our health potential, our health outcomes that come from when we sense unjust or unfair differences. And part of the idea of health equity aims to reduce or eliminate these disparities. And some other concepts that are quite related are health inequity and inequalities, where health inequity points towards those differences in health potential that are avoidable for unjust, and health inequities are mostly those differences and variations. Mainly health inequalities are not necessarily unjust, but when we are talking about health inequity, we are focusing on those differences that might be structural or might be, that are unfair or avoidable. So having kind of, defined those key terms, I'm now going to go or move towards the part of the session where we present a bit of how AI systems have been part of, or not independent of the social environments, which we are. Also kind of integrate some of these or are shaped by these inequities. So first of all, many of you might some definitions for AI system, but we also usually start by giving the definition that we use with systems, which are computational software-based systems that use statistics or methods-derived statistics, mathematical techniques, and more to carry out tasks usually associated with human intelligence, or that would otherwise require human intelligence. And we are going also to talk during the session about other terms, related terms, biases, discrimination, and so on. So basically, when we talk about biases, we refer to evaluations that we make about someone or something that might be negative or positive. Biases that are implicit are those of which we are not aware of, and specifically those negative implicit biases are the ones that we are most going to talk about today. And as not only humans or institutions have biases, but also the can have biases, having the effect of potentially leading to discrimination, and when discrimination becomes embodied, then it can lead to health inequities. So when we talk about biases in AI systems, we're going today to present this 4-quadrant framework to understand that, and we're going to go through 4 different contexts. Data, design, development, and deployment, ecosystem, and social world. So we're going to start with a data context, and we're going to move to another question, which is, which data tasks are most likely to result in bias in AI systems? And we have a couple of options there. We're going to ask you to maybe answer or choose up to 3 of them. And yeah, we have maybe, just after minutes or 45 seconds.
Yeah, so these are just a selection of data tasks that you might as statisticians use. I mean, some of them are quite big categories like data processing or data pre-processing, for instance, where you may have different steps in there. But basically, it's just getting you thinking about the data tasks themselves and as an entry point for bias or already bias embedded in these. So just take a moment to think about some of these and just do a selection of where you think bias could most effectively enter into a task. We'll just give it a few more seconds because this one's a little bit easier to do as a selection. Any responses there? All right, we'll just see how we do. That's a good cross section of areas, and interesting that we included some data stewardship tasks here, like data retention and data transfer, data use. So that's interesting that they weren't picked up as much. But can anybody say anything about their choice, why you think this task would be ripe for bias? Anyone online? Anyone here?
For an example of a moment where if you work with data that you encounter these challenges, so that you identify that certain activity related to the using data might lead to this.
So Leandra, yes, if you can, anybody would like to say what they feel is a main entry point for bias. And it doesn't have to be the top one, but any of the ones that you think may have some bearing on it.
So in terms of the integration, I guess in a way, there's a lot of the issues we tend to talk about, but talk about specifically problems of things like diagnosis, background engagement with healthcare systems, and things like that, which I guess introduce problems from the moment the data was created. And although you can, I guess in my view, do better things at pre-processing to account for them if, for example, people is noisy than another, unless you go back to creating new data, there's not much you can do. You can definitely make it worse. I guess that's why I took the creations, the first one.
That's good, thank you. Anyone else? Anyone else with a different lens?
I've chosen data processing and data analysis, mainly because I've worked with clinicians in the past, doing statistical analysis. And most of the time we have, for example, specific groups that weren't represented in our sample, for example, extreme ages, very young people. And the advice of most of those clinicians is that since we don't have information about those people, just remove them from the analysis. And it's the go-to process in most of applied data analysis that's happening out there.
And we have one more that might be just different than anyone else.
There's two
online. Yep.
This person didn't say what they chose, but they said some groups are systematically excluded from healthcare and state election. Some groups are excluded because of small numbers, suppression, tendency to overrepresent the average. Collection. And then someone said different data collection criteria or standards, dissimilar data features of data transfers, data collection bias at surveyor level, not creating research based on good questions. And then someone added saying non-standard data categorization.
Those are really all good responses. And interestingly, if we're looking at AI systems from a machine learning perspective, a lot of work happens in data pre-processing, like data cleaning, data transformation as well. So if we're thinking from building a system and on data that may already exist, for instance, that's another consideration. So whereas bias can go into any of these categories, and even in data retention. So what do we keep? What do we throw out? And data transfer, again, we're always making decisions. So as statisticians and data scientists, data is the data infrastructure of AI. So all of these processes, these data tasks, all have implications on where bias might enter. So anyway,
yeah. Yeah, because I guess we're reiterating many times in this session, a lot of the design and building of the systems rely on human decisions, and the data aspect is not independent from that. So if we go back to the presentation, we have as well encountered some of these examples of points where we can find biases. Some of these biases result very much from patterns of bias in the real world that are then embedded in data sets, things related to clinical trials, for instance, that have underrepresented certain population groups, and then if we use those data sets, we might have discriminatory outcomes as a result from that, or if we're using clinical notes as part of our data set, they have reported that implicit biases, again, this real or possible discrimination might be fed into the system. But we also have other things with some of you mentioned something biases, there are also measurement errors. We have for quality, we have a clinic that is heavy, how heavy workload, or it's not digitally mature, that we struggle to collect data reliably and consistently. Again, things related to personal biases that might shape our coding. There are reports on the amount of people from minority ethnic groups that are usually categorized in hospital data that others are not known in that category. So there, what happens is that we don't have that, it obscures the needs of those population groups, and ASC groups that would then be not as, would not perform for these people, but also might then lead to health inequities. So this is one of the dimensions, and then we also have the big dimension of which actually entails the whole data life cycle, so these stages that are part of the process of building an AI system, from its very moment of creation to its deployment, monitoring, updating, and provisioning. And here we also have one question for you, which is which factors could contribute to unfair bias in the design of an AI system? When we call here, when we mention QA design, we refer to the whole AI life cycle. Could be at the design moment, at the deployment stage, and so on. And this is an open-ended question, so please feel free to fill that with examples if you have comments and so on.
Yeah, so if you've been involved with systems from the outputs or from the design, software as a medical device, probably also familiar with risk scoring systems, perhaps. So all of these are basic tools in which we have maybe an underlying algorithm or decision-making tool, which can have bias enter into the design. So any of your thoughts or experiences are all open to, in this question, we're open to all of your ideas and thoughts. Give it a few more seconds. And then it'd be great to also invite you again to respond also on your choice of factors. Okay, let's see. Got a few more coming in. Sorry, we're making you work after lunch. I know it's harder. Okay, I think we'll start the conversation. So these look like very exciting responses. And what's great about, I think, the way you've approached it is you're looking through a socio-technical lens, which is exactly where we're going with some of this in terms of how we should be looking at the design of AI systems. So, wrong incentives right from the beginning. You know, what were the incentives to design an AI system? Was it consultative? Are we really taking on board the needs of the population which we're trying to serve and support? So, and then who's involved in that consultation? So we've got participatory bias, which is a very good one. So anyone who's done action research or anything else, you know, with communities or larger groups, how do we account for fair representation? And what different modes of participation are appropriate? You know, and then we also have some of the actual data methods and computational methods that can contribute. And statistical bias and bias as we see it entering systems have correlations as well. So, you know, how we approach outliers or how we deal with observatory bias. So all of these are you know, exactly where we're heading in terms of thinking about bias being a very challenging area of understanding, you know, how a system is designed to its deployment. Anto, I don't know if you'd like to say anything about what we see here.
Yes, it's very interesting to see the different things, and yeah, like having that kind of technical approach to what the design of an AI system is. Many of you mentioned how the team is integrated, the life experiences of that team, and definitely this in the different stages of the AI cycle, this will have its impact, of course, with this mix of, you know, perspectives, objectives, even priorities. So yeah, I don't know if anyone wants as well, again, we invite you to maybe explain a bit more about your answers. So if you come across some of these issues during your own research, or you know, about any use case that you want to.
Has anybody been involved in the design of software or a risk prediction device, or feel free to talk about where you think this is, you know, why you responded about this in this particular way, from exposure to the clinical environment, or we'd welcome your thoughts.
It's just like something, a version of something that somebody is doing research on personal assistance and comparing different countries. So, one from the US, one from Russia, one to see it on the Eastern times in just I'm feeling low today. And then the American version would say, if I had arms, I would give you a hug. To get back on track on something about the Russian one would say life is not always easy. Like it's a sort of also cultural factors in this, where does the system go and those things.
Yeah, very, very true. Do you find that there's an overdependence on personal assistance that might be dependencies on personal assistance? Do you think there's something entering there that might be a challenge?
Yeah, it's not. I almost.
Yeah, it's very interesting to see that space. I mean, you know, from Alexa to, you know, Siri and personal assistants, and how culturally they are shaped to support people from different countries or different needs, and how we might perceive bias in that. I would see that is very challenging, and how we, yeah, as a challenging system to develop. But definitely one that a lot of healthcare providers are rolling out for people in social isolation, you know, older adults, to people, you know, needing care at home, to mental health cases. And each of those, again, looking at the social determinants. Are we looking at different blindness in the development? And harms that might ensue. So absolutely, these are really important questions. Sorry, Leandra, do we have another one?
It's not really online.
Good. Yeah, don't worry, this, oh, sorry.
It's kind of related to one of the points there around being optimized for the majority group. So there's like interesting examples in genomics where the reference panels being used are very much based on folks of European ancestries, and that has like effects throughout like the design of, say, risk prediction models from like imputing data, like correcting the missing data in genomic sequences. You kind of assume that it's got the same structure as people of European ancestry, which doesn't necessarily generalize to people of other ancestry, to even just kind of aligning genomic sequences in the first place, very much based on an unrepresentative sample. So there's kind of like an assumption of homogeneity. It's not necessarily the same as being optimized for that like particular group, just assuming that everyone fits within this bracket.
That's a really good example. So we'll go to the next step.
Sure. Yeah, I think many of the things that as well we identified in our research also relating to the main examples of the things that you could implement into things from, and you some of you mentioned like the different, yeah, how we shape the research agenda. Like it might be that there is a project team, but there are decisions made at another level and they have different priorities, or yeah, how we define or design the problem or select the problem of the RNA system, to other things related to the feature selection, what are the models that we are selecting, and so on. So these are some of the things that you've already mentioned. I think definitely we can go to the next one, which actually relates to ecosystem. Some of you might have already like identified some of the things that we were talking, but that this is maybe, you know, like the ecosystem where the AI systems are when they are deployed, the entire market of the entire ecosystem of market, of policy and political decisions that shape or steer the agenda of innovation, and also can shape the impacts that the systems will have anymore. So this is a question that we have for you at the moment. Yeah, I'm going to that. So yeah, here the question is which external factors could most influence an innate system or in the sub-count. Here we are asking to get rid of like ranking on those factors.
Well, we will do that. Could you maybe define the difference between social and cultural?
Very good question. So I think some of the examples were definitely related to cultural, like the gentleman that was talking about personal assistance in different countries and how the personal assistant was sort of developed within a cultural context. Social goes, I think, back to the social determinants like education and things that affect us socially in our lives, like income and education. I think we'll do a reveal. I think that's oh, we're still going. Any more people have a change in mind? That's okay. Or add to it. Yeah. I think this is definitely a deliberative one, and thinking about your personal responses to this. Does anybody want to say why they've chosen one or the other? Or put one last, or one first, or unsure?
If there are similar patterns in data context, like for example, people are building more activities, properly people have different ways of treatment preferences. Like not modern red alternative and so I think and also like people might respond to the international correctly and then they might have just
I think it's all true because I think it acts over a long time period, like culture is mainly over like centuries and centuries, whereas politics change, economics change, all the other factors tend to change more rapidly. So I think culture will be the biggest part of the impact of society, and so creates the data that goes into.
So admittedly, I missed some of this as I was so heavy with my questions. However, I would have put economic, and the reason I would have selected economic very specifically for the build out of the systems is the cost of application. So models, as you're continuing to build larger and more sophisticated models, there comes with significant cost in compute. And if we look at things like emergent behaviors that come with additional compute, obviously that's an economic problem.
Anybody online or anyone here? No from online?
So admittedly, I would like your last now think a little bit more about it. I think maybe it's going to be Helen, sure, from situations, but I know in company where the use of some of the ways in which you defend effectively, like for example, basically like decisions regulated legally, I think although maybe since now we're at such an early stage of figuring these things out, we're not too much thinking about the legal implications. It might become very soon sort of that hard wall that even though we think we know, it's always saying, see, we cannot allow to. That goes to be political, I guess.
Thank you for that. So I think there's no right or wrong here. I mean, I think we have to also think about the ecosystem which we're in right now, where there are only a few big players determining what is shaping an AI system. And they're rightly taking cultural social data from the internet, aggregating a lot of what we see in generative AI systems, for instance. We see a lot of economic basis for these models, and they are consuming a lot of power and energy, and they are very, very costly to build. If we're looking at smaller instances of where data is going with healthcare, which might be more customized to a population. I mean, I think when we're saying AI system, it's a very generic view we're looking at right now. But if you're going into the medical field, and right now there are no large language models that are strictly for medical healthcare. There are ones being developed by Google, for instance, called MedPalm. And so far its big deal is that it can answer questions on the US medical licensing exam. So, but context matters. And so, you know, none of these answers here are wrong, because if we're starting to contextualize what factors influence an AI system, it's going to be very much contextual. And legal being last is not surprising, but if you're thinking about lack of regulation and other things that are related to the ways we might interact with an AI system, that could become very important. That was something that came out of the AI summit, safety summit, for instance. So, and institutional, you know, the influences we have as academics, as people who are part of institutional systems. So we have bearings on across all of this. And I don't know, Anto, if you want to say.
I see the words in changes. But like, I mean, the exercise is that to be able to, or to also encourage to think about the different dimensions of factors that could influence AI systems. And some of the things that you mentioned, like in terms of economic, you know, venture capital investments in the UK are mostly concentrated in companies from all the world, which a lot of what does this mean for equity? In terms of the legal aspect, I'm going to go to that one that is the thing at the moment, but MHRA, you know, has this sort of kind of requirements for AI systems in the health and healthcare sector are putting to the market that will influence its systems or lack of such requirements will influence how AI systems are designed and are deployed. In that sense, for instance, when we were doing this research on health equity in AI-enabled medical devices, we conducted a few interviews, and it was interesting to see how many of the interviewees, for instance, commented or had some insights around wellness apps, which by themselves they are not, because of how we define a medical device. They might be in that gray area where it depends on how the user uses that app, whether it was or is a medical device or not. So if we have, you know, if there are certain gaps in the legal frameworks or so on, like that will also influence AI systems that are available, how they are framed by companies or who are deployed them. So these are all like, and at the same time, quite, you know, factors that interact with each other. And as you mentioned, there are things that are more, I mean, more stable that have been there, you know, for a couple of years, and things that are changing quite quickly, as for instance, some of the political aspects, whether there are, equity-driven health policies and so on. So, that's a bit of the ecosystem dimension that we, promote or encourage you to think about as well. And lastly, the fourth dimension, and some of the things we have also been talking about. Oh yeah, we kind of covered this while reading your answers. But yeah, these are a few things that we've identified while doing the research. But if we go to the following dimension, that is the world. So here there are a few things that relate a bit to ecosystem, but actually the world is mostly those things that precede, or those aspects that precede the design of the AI system. So here we can find historical biases, structural racism, institutional biases that feed into the AI systems and the data set themselves. And here, this is like specifically for the health and healthcare sector, but some of the patterns that we identify relate to some of the things that you've been mentioning throughout the session. How unequal access to resource allocation might influence how then the data sets are constituted, or in the case, for instance, of research agendas or medical research agendas, how for some years they have neglected some population groups, and then the knowledge that we had about their specific needs or health, the health experience, life experiences, had also shaped how we understand certain medical context. And if that knowledge has neglected certain populations, then it brings to the moment of the design of the system, then we will have quite a biased design or approach to the selection problem or the design of the problem itself. And some other things that we've also been talking about, as like the underrepresentation in genetic studies, biased medical training, and So, in summary, this is a four-quarter model that we use a lot to kind of think about the potential biases, world data design ecosystem. What in a way we want to illustrate with this is how AI systems are shaped by potentially biased human decisions, by potentially fallible human judgments, and potentially unfair or unjust social structures. And as we mentioned, and this we call it as having a cascading effect, because the patterns of bias and discrimination in the world will be baked into the data sets, might also be embedded at the moment of designing the system, through the human decisions. The data, again, will feed into the AI systems, and both the biases that emerge at the design point and the ecosystem world will also go back to the world and the data that we use to train, test, and validate the AI system. But why we call it as having a cascading effect. Under that, and so this is the last bit of the session. We talked about, like the big areas of concern that we have, and where do we go from here? For the last years, there have been a lot of discussions around what are the guiding principles to propel responsible innovation. At the Turing, we have created guidance around these 6 ethical principles, which we call safety. And that stands for sustainability, safety, accountability, fairness, explainability, and data stewardship. So basically, sustainability, having this sensitivity to the potential impacts of social environment, human factors on the AI systems, and how AI systems have impacts on, again, the social environment and human factors. Safety relates to ensuring that AI systems are accurate, reliable, secure, and robust. Accountability, which aims to have very clear roles and responsibilities and points of contact, as well as making AI systems and other processes auditable. fairness, which relates very much to what we have been talking during the session, which requires non-discrimination and how we take bias mitigation action. Explainability requires that we are able to explain to the different stakeholders what are the outcomes of these systems or the why of these systems and the processes around them, and then we equate those explanations depending on, of course, the context of what is explanation that is needed and the stakeholders that are required of those explanations. And finally, data stewardship that relates to making sure that we that requires data quality, integrity, protection, and privacy. So we're going to go maybe to the last exercise, I think. This is a use case that maybe some of you have heard of. Yeah, I think it's in the same presentation. Yeah. So this is taken from Overmeyer and colleagues. I since some of you like I know this one, I've heard about this one. So basically, this was a model that was designed to help refer patients to specialized healthcare programs such as prioritized appointments or home visits. The AI project team aim to give scores to the health needs of patients in order to refer to the type of specialized healthcare program that they needed. And the target variable that they chose was health needs, and the measurable proxy for that was patients' history of healthcare costs. So after they put this into, the employees, they very quickly realized that this actually had different performance between different population groups. So actually what happened is that the system predicted lower health needs for patients from racial minority groups, even when they have equally unhealthy conditions to other patients from majority racial groups. So taking into account and consideration this case study, we're going to go to the last activity, which is considering the different ethical principles that we mentioned before, and how would you rank these ethical principles to address the use case that was just presented. Can you put the explanation of slide with the principles back on?
Certainly. Can everybody read that all right? Can you read the slide? And
yeah, sure.
Yeah. So these are effectively a set of ethical principles or guardrails. And even though data stewardship is not itself an ethical principle per se, it has a lot to do with data justice and legal parameters as well. And that's why it's sort of last. But there are attributes to each of these as well, which we can discuss after the Menti activity.
Is this ranking how well do you think that he did it in Spain, or what he needs to, the most important things to improve on?
To improve on, yeah. Because it's a retrospective use case. The algorithm in question what was a rescoring algorithm that was rolled out in the US. So we're talking about the US health system. So I guess there's a cultural context to that too, because of the way that their health system works in insurance and private insurance companies, healthcare providers versus public. So it has a lot of challenges to it in the first place that are not even addressed by the issues with the algorithm itself. So if this was an NHS model, that would be interesting to understand as well. It would be probably quite different. Okay, I'm going to go to the Menti now and just see how we're doing. Okay, give a few more seconds. And it's okay if you change your mind when we bring it up. Because it's really around reflection on how, if you were designing a system like that, you know, what would be the first points of ethical principles you might apply? And it could be addressed through evaluation as well. And I think that's one of the things that, you know, we're giving a sort of set of tools that you can think about through the life cycle of an algorithm or a system. In the interest of time, I think we'll keep going. Good. Very good. We have any folk who want to talk about their choice? I'd be very open to hear your thoughts on what might be a first approach. Or one you didn't choose because you didn't see it as relevant.
So I did put fairness first. Existence, I think, but then I also put accountability. So that goes in it and explainability, because it seems to me a good example of people were really accountable stakeholders and properly talking to the kinds of people who have a stake in this sort of model, and thinking about how you explain what you're doing to other people and allow their feedback. We wouldn't have ended up in situations, and pointed out along the way where that line thinking and that design was taking.
Any others want to relate to any of the other principles that may not be at the top but not be somewhere else in this ranking?
I think that they should have checked a little higher. Mine is because if issue fundamentally comes from core data quality, if you're thinking about whether the data represents population and if there's this also on the outline of severity, what you could notice this a little bit.
Anybody else? Anybody online?
If anyone online wants to say something, put it in the chat.
Okay. Well, we're going to give you some resources to explore these principles a bit further. Because obviously, given time, we haven't been able to go through all the attributes of each of these principles, which may also, you know, give you a little bit more food for thought in the rankings. In essence, they should be all taken together and shouldn't necessarily be a ranking so much. But it's interesting to see a use case retrospectively against principles and where you might start. Because even though these principles are, you know, separate principles, you have to start somewhere. And very good thinking about data stewardship, for instance, thinking about the data in which we might, you know, start from. And then the fairness where we might mitigate bias. But also the safety question, because this is so, you know, for us in healthcare, the patient safety is number one.
Yeah, and I think one of the key things, again, like the relevance of each one of those principles is quite evident, as usual, like for the different ways in which you could argue, yes, this principle needed to be taken into consideration for this reason. One of the key things as well is the importance of addressing this or having like these principles as guides from the start of the design of the AI system. Because in this case, the fact that the AI team chose the history of medical costs as the proxy meant that they were not taking into account the social determinants, also the fact that some population groups might not have the same access to healthcare for different reasons, because they had to take their day off at work, or because they don't have, or maybe they had, awful experience going to a clinician, and they don't really want to go if they can avoid that. So that type of awareness is some of the things that need to be already present from the very beginning of an AI project, and the relevance of having these principles as some guiding ones. And as you mentioned, like considerations of how an AI system might have disparate impacts or might be discriminating, and so on, like relates very much to fairness. Some of you mentioned explainability. How do we explain people who have been disproportionately impacted by the system? Why the decision was to give or not? Like, does this specific, if they had prioritized appointment or not? And again, data stewardship. How are the data collected? How were the sensitive data as well protected, and so on. And so these are hopefully guiding principles for any AI project. We have developed guidance on how to put them into practice, because they're like super nice. How to develop principles. But the key thing is that we actually take actions for processing, for procedures that actually help us integrate these at every stage of the AI life cycle. And I don't remember how many minutes we have, so up to 5.
5 minutes? Okay. Yeah. So absolutely. And I mean, maybe you can tell from my accent, I'm actually Canadian, not American, but we're having a very interesting problem right now, which this use case is actually quite relevant to. So a lot of people don't have GPs anymore. They're going into emergency for their healthcare. And those people wouldn't be seen in an algorithm like the one in the Obermeyer study, because more people are going to get treatment through emergency rather than through GP. So those statistics are not being shown. And I think COVID must also have impacted greatly on the situation. So it's really thinking about very holistically about, again, bringing in the social determinants, and also then thinking through these contextual ethical principles as well. But so we're all impacted in some way. And sorry, I got the wrong. That's interesting. There we are. And we'll go back now to. Did I go?
The animation there is a 5-minute one, but
do you want me to?
Yeah, we can maybe wrap up, or what do you request? Okay. But yeah, we're going to leave all the resources, so yeah, you can have access. This is part of a project that we've been working on how to put ethical principles into practice. We have developed a series of 8 workbooks. 4 of them are published. We published them last Thursday. The 4 other ones are going to be published next year. And there you will have, like you can deep dive into what these principles mean, the different terms and concepts related to them, but also the governance actions that you can implement in an AI project to guide and propel responsible innovation and you can, like, we also developed it in a way that you can conduct workshops for different activities and to better grasp the terms of the action side we propose there. So yeah, this is an animation that is to explain the framework that we elaborated. And maybe we can go to the very last slide where you can scan the QR code to have access to those resources. And if you do use them or you read them on, you have feedback, we're very much open to receiving feedback and knowing how this can be used for you, because this is something that we are able to continuously improve from the experience that people have using them. And hopefully we finish with the session with these new results for you, and happy to have any questions after this come to your comments. Thank you very much.
All right, thank you so much for this session. This is really very, very interesting. And here's the code, and we'll share the resources afterwards, along with the recording. Right? Yeah.
Awesome. So it's time for coffee once again. Antonella and Anne will be staying around for coffee. If you've got any questions, comments about the workshop, then please feel free to give us them. We will start again in 25 minutes, so at 3:30 with our final session today. I can see that all the panelists are here up on high, so that's great news. So see you all in 5 minutes.
We're happy to share slides and things too, so don't hesitate to email us as well. We'll work through Leandra with the resources. Yep.
Awesome.
No, I make that.
Alisha, nice to meet you. Where have you been?
I'm based at LSE.
I know we've been in various.
We are ready to get going for our final session of today. And this is a very exciting panel session. And I will leave you in the capable hands of Claire for this session. So over to Claire.
Okay, can everyone hear me? Okay. Hi everyone, so my name is Claire Coffey and I'm a PhD student at the University of Cambridge, and I'm very excited to be sharing this panel today, which is all about bridging the gap, translating data science research into actionable impact for more equitable health policy. And so this is something that's been on the mind of us as the organisers, and something that we'd really like to learn more about, how to kind of translate our research into health policy. So we're very lucky to have some fantastic panelists here today to discuss this topic, and they each bring their own sets of expertise. So firstly, we've got Miqdad Asaria, who is Assistant Professor at the Department of Health Policy in the London School of Economics. And then we've got Mai Stafford next, who is Senior Analytical Manager on the Data Analytics team at the Health Foundation. And finally, we have Alisha Davies, who is the Health Team Lead for the AI for Science and Government Programme at the Anne Turing Institute and Head of Research and Evaluation at Public Health Wales. And so I'd like to kick off the panel by just asking the panelists to introduce a little bit more about themselves and their backgrounds and their work. And then I'll go ahead and facilitate the discussion with some more questions, and then also be time for some questions from people online and in the audience too. If you'd like to start, go ahead.
Hi. So just working, yeah. Perfect. So my name is Miqdad Asaria. As I said, I'm Assistant Professor at the Department of Health Policy at LSE. So I started out my academic life as a computer scientist. And it was kind of during the dot-com boom years. Many of you probably weren't born then, but it was back in the day when the internet was kind of becoming a big thing, and it seemed like data and the way we use it and the way we communicate was going to really transform our lives. And so I was really quite interested in all of that. And as I got more interested, I found actually maybe you need to combine some of that technical skill with some social science to really understand those broader implications. And so I retrained as an economist and eventually did a PhD in health economics. And so And over that period, I got increasingly interested in health inequalities, inequalities generally, and health inequalities. And so a lot of my research has been using data to try and understand health inequalities and try and think about how we might tackle health inequalities. And so I've done various bits of research measuring inequalities, creating indicators for government, thinking about how to tackle inequalities in economic evaluation methods, and also thinking about how the social value judgments that go into inequality policy, rather than just the technical kind of measurement issues. So I'll stop there and we can pick up in discussion.
Hi everybody, I'm Mai Stafford from the Health Foundation. So my background, I did maths to start off with, and then moved into social epidemiology. Actually, I worked in academia for quite a long time. So I was here at UCL and did my PhD in health inequalities, looking at neighbourhoods and health. And while I was here, my first role was introduced to, became part of Michael Marmot's team, and that's where I was sort of introduced to the idea of health inequalities, and that's sort of a lens that I've brought to all of the work since, really. So after several years at UCL, I've recently moved to the Health Foundation about 5 years ago, and just in case you don't know so much about the Health Foundation, we have a data analytics team that does several things, but using data science to describe inequalities and understand some of the health challenges. And then we do evaluations of health and care initiatives, and also funding awards, particularly to analytical teams, so that they can tackle challenges in health and inequalities. And we're also within the wider Health Foundation, where we also are doing work to sort of improve the nation's understanding of the wider determinants of health, so some sort of framing and also some campaigning where we try and join up organisations to tackle inequalities. So I guess my work sits within a wider environment where a lot of colleagues are frequently in touch with policy and service leads. That's where I am now. And over to you.
Thanks, Mai. I'm Alisha Davies. I'm the head of research and evaluation in public health Wales, and also for a couple of days in the Alan Turing Institute in the health team there in the Health Crime Challenge. I started out doing my PhD in epidemiology at the London School, just down the road, and that's on inequalities of cardiovascular disease and absence of treatment across the 4 countries of the UK and Northern Ireland. I'm really passionate about the equity across different parts of the UK. And then after doing my PhD, I was thinking, I really like this, but I would like to be closer to the system side of things. So I joined the NHS Public Health Consultant Training Programme. I got a place here in London, and that's a training programme for both medics and non-medics in public health, if you have experience in that area. And that was fantastic. You work across all parts of the system, from local government, acute trusts, policy think tanks, the old integrated care boards and the pieces that were there beforehand, and health protection and sort of thing. And from that kind of career, and I had a couple of jobs in other places, and then moved to Public Health Wales to lead to grow actually our research and evaluation team that sit within the NHS. Public Health Wales is still in the NHS, but deliver academically rigorous work that we publish, we bring in grants, but all of it is focused on actually trying to address the questions that Wales needs to answer. Sometimes we get it right, sometimes we don't. And then the last bit about the Turing, I'm curious, I'm interested, I'm not an AI scientist, but I'm really interested about how we can bring AI into the realms of public health and population health. So at the minute, a lot of the innovation in AI is more in healthcare and clinical health. So how do we start thinking about applying those tools into the really complex challenges of health inequalities, for example? So that's me.
Okay, thanks everyone for giving us a bit more info on you. So really, well, I'd like to jump straight in kind of at the deep end. And so something that has come up a lot, and you've also just mentioned in your introductions, is what are the key challenges, do you think, in translating data-driven insights into actionable health policy? And really then, how can these challenges be overcome?
Shall I start?
Yeah, go. Any order you wish.
This is just a reflection of over kind of the career things. But I think the first thing about it, one of the biggest challenges is that sometimes we think about that as an afterthought. How do we get what I've done, which is amazing, into policy or practice? Well, actually, that's too late. So the first solution is make sure that you're addressing a policy gap or a need, and talk to the people before you even start about what you're trying to do. So kind of co-production is really important in there, whether that's NHS, local government, and even a third sector, charitable organisation. The second, there's two others, and then I'll pass over. The second is about what the other thing that we get. Even in R&D in public health fields, we're trying to do this better, is how we present our findings in a way that's usable for people, that they don't need an explanation to use them, and actually it gives them the information at the granularity that they need it to be able to inform decisions or inform thinking and inform debate. It's not going to be used if your bad work is sat in an academic paper. And the last one is more to do with the development of tools, so data science that creates tools that then you might want to put onto an NHS platform or a local government data system. And what's really difficult is sometimes those systems don't accommodate the tool. So it can be something as simple as the computational power in that system won't enable something like that to run, or that there are wider updates on NHS infrastructure that will delay your innovation getting put into practice. So and that can be frustrating, but I think the lesson of that is always going to be a challenge. But just be patient and just keep going, and it will get there in the end. That'd be my clue.
Thanks. Yeah, I completely agree with those, and yeah, that was my first thought as well. That it has to start with who's involved in kind of asking a research question and who's involved in designing that, and are you talking to the people that are going to be using that evidence afterwards? Are you talking to them right at the start? And it takes quite a bit of time to sort of find the right people to ask and to build a relationship so that they're going to give you that information. And I think that's why I mentioned that I'm in a kind of wider organisation where a lot of people are doing that and building those relationships, and it's pretty difficult to do it by yourself, I think. And then involving people, those sort of user stakeholders all the way through as the work progresses as well. That's also important. And I guess something, we have to also think about the balance between being independent and doing a robust and independent piece of work, as well as kind of involving those stakeholders as well. And then the other sort of main thing was whether you've got a theory of change, whether you know what you want at your endpoint, and are you mapping out what the stages are in that, what activities and what kinds of outputs are going to help you along the way to get that impact. And I guess, as well as involving the stakeholders, sort of particularly thinking from an equity point of view, also bringing in people with lived experience, people from you know, groups that typically wouldn't be involved or asked to take part, people that are at the sharp end of inequalities, I guess, and that's also something that we're increasingly trying to do, but recognising it's quite difficult.
So I agree with all of that, and I think it's also just worth, from an academic perspective, just thinking about timelines. And academic work takes a lot of time, and policymakers have very short attention spans or lifetimes. Yeah, and you know, right now you might think I should do something about levelling up, but then you might think by this time next year we have another government, maybe, and they might have some other buzzword or some other policy that they're pushing. So to some extent, yes, you should keep an eye on what policymakers now are thinking, but sometimes you should also be interested in something and be interested in something that you think is important and pursue it, and make sure you produce robust, credible academic work that persists over time. And then I think separately to that, you can communicate that into whichever policy environment happens to be fashionable at the time by writing policy briefs or other kind of you know, ways of communicating these things to policymakers who have very limited time to read complex research articles, who need answers to specific problems that ministers are asking them about day to day. I think it's really very valuable for anybody working in research to spend some time in policy. I spent some time working at the Department of Health in this country and the Ministry of Health and Family Welfare in India, and both of those experiences really blow your mind in terms of, like, you're sitting on the other side of the table and you see what the challenges and pressures are, and I think it's very different. And so I think, yeah, don't necessarily create your whole research agenda around a current policy priority, because tomorrow that might be gone. But do tailor your output and communicate it into current policies when your output is ready, and keep doing that. You know, as governments change, policymakers change, or as you look at problems in one country to another, think about how what you found is important and relevant to different problems, and pitch it into those different problems.
Could you expand a bit on writing policy briefs? I think it's something a lot of people in the room wouldn't be necessarily familiar with, but what's the kind of like process behind that? I guess it's like standard position today, wouldn't cut them struggles to that one. So talk a little bit about that.
I feel like this might be
Yeah. There's so different kind of approaches to policy briefs, but in other words, we're trying to frame your findings linked to the policy context. So why is what you're producing or your work, your career's work, why is it important at the time right now? And what's the most important thing that from it finding or insight that actually will help in terms of the civil servants that are helping the ministers to shape their thinking. There's the governments and governmental departments will put out calls for consultations, and I had a quick look. There's the UCL, it's called UCL Supports Impact on your UCL group. That's one example, but other universities have them. And there, if you talk to them, they will keep an eye on what consultations are up, and they will be able to point you to, oh, you've said you're interested in these areas. This is coming up. The other thing is it's called post knowledge, or post.gov.uk, I think it is, and that's a part of UK Parliament that does just that. It tries to bring together the called post-it notes, but on a particular topic that ministers might be interested in. They'll draw on research and evidence, and actually you can sign up to that and say, this is my research area, and if there's any in this area in the future, I'd like to help in some way, or that type of thing. So that will give you some experience. I don't know. Health Foundation does a lot.
Yeah, just to add a very sort of specific thing to that. So we tend to, once we've got our kind of emerging findings and got a draft, we'll tend to go and ask some people informally, policy stakeholders informally what they think of it, and sense check, is this going to land okay? And also they often help you with, oh yeah, this fits into this bit of policy, and help you draw things out. So yeah, you can draw on their input as well.
So maybe one thing I didn't say is that I also have a fellowship with the Health Foundation. And it's been really interesting interacting with the Health Foundation because they have this brilliant research team, but they have a equally large or maybe larger communications team. And just as a researcher, you're initially like, you just wonder, like, what are all these people here for? Like, there's these people like May who does all the research, like, why is there this whole other bunch of people? And then you realize that that's why they're quoted in the newspapers every day. That's why their ministers take what they say seriously. That's why there's a big process between that intellectual work of producing a result and actually pitching that work into policy space. And it's not, I think often like we see that as trivial or not our, and maybe it's not our space, but it's a very important space, and places like the Health Foundation have clearly embraced that. So every time you do a report for the Health Foundation, they have this thing called like it's called the runway or something, and the communications runway, and they put you into a timeline where you have to, it's like going into an airport, and you have to plan from long before when your research is going to be done, and then when it's going to be pitched into which policy discussions and which newspapers are going to speak on it. And so it's really quite an interesting process to think about as a researcher.
It takes a lot of resources. Yeah.
It's not just like as a university academic, you just think maybe I'll just tweet about my paper and that will be it. And that's not enough apparently.
Yeah, thanks for that. I think those are some really valuable insights, and I kind of have a question that's a little bit of a follow-up to that, because as like a early career researcher, I kind of think, well, nobody's going to really take any notice of anything that I do or say. And so what advice would you give to emerging data scientists and researchers who are interested in making this meaningful impact on health equity, but how can they actually begin engaging with policymakers?
Yeah, want to take it in turn? Yeah, I think we've just been saying some of this, haven't we? So if you're a lone voice, it's going to be really difficult to have impact. So finding allies to help amplify those messages is really crucial. And there's lots of networks, aren't there? There's I guess I've been really impressed with the NHS England Health Inequalities Network, which is kind of most relevant to my work at the moment because we're looking at inequalities in health and social care. But yeah, that's a really active network, and every month there's presentations and you can volunteer to present and you can ask questions of people and sort of get yourself and your work known through those kinds of things. Maybe this is a bit further from actual policy impact, but you can propose topics to funders. And I think, I know NIHR has a mechanism for anybody, public researchers, anybody to suggest topics. So at least that might be a way to get some resources to get additional capacity in your kind of research area. And then maybe another one is about engaging with analytical teams in other organisations. I guess I'm particularly thinking, for me, it would be Department of Health and Social Care or public health analytical teams, or maybe ONS. Get them to tell you about their work, build some sort of analytical networks. It might be a way into understanding the policy angle in a more of a language that as analysts we can understand and find some common ground in.
So I guess it's something I briefly mentioned before, is that it's really valuable to spend some time in that policy space. So if you can find some opportunity to do an internship or a secondment or even just a job for a little while in one of these policy organizations, I think that it's just really helpful just to be immersed in that and really understand how does a policymaker think, because you are a policymaker, and then come back again and think about how would you want to communicate with that policymaker.
I'll just add one thing. I'm pretty sure UK Gov has secondment, or I'm not sure if it's secondments, but placements for PhD students for like 12 months where you can go and do placement with them. I think it's like an annual thing that you can sign up to do that. The other thing is just be patient. Like, you're not suddenly in 2 months going to have a whole big network of policy and people that you're going to look into. But if you just set aside like an hour, a couple of hours a week, which would be joining NHS England's Health Inequalities Group or some of the other networks and things, you'd be surprised how actually your network widens and how through people then you find other people that are really interested in your topic or actually want to know what you're doing because you're offering like solutions or outputs that they can use, and yeah, it can just grow that.
Yeah. There's a couple of related questions in the chat. Either end of the kind of the spectrum in terms of one is very like hyperlooting and the other one is very concrete. So I'm going to ask both of them. So you can choose which one. Or both. So one is generally concrete tips on how to communicate nuanced research insights to policymakers. And the other one is kind of almost getting at kind of activism, which is like how do you help drive massive consensus and adoption, have impactful long-lasting change. So one is like specific like policy tips, sorry, communicating research insights. The other one is almost like breadth of policy, so not just like a single policy, but how do you like help drive massive consensus adoption.
Can you repeat the second one?
Second one is how do you help drive massive consensus and adoption and have impactful long-lasting change. So I guess if you have like a slew of policies that you want to get, maybe like something like leveling up, but that the government had already decided you want to drive forward some specific change, or that not something which is taken to research is not hard.
I'll have a in terms of the specific things that you can do, I think I'll go back to what we're kind of reflecting on is trying to write for a non-specialist audience. And the more, and again, that's something that you don't just suddenly become really good at overnight. It's an art, and if you can draw on past experiences, then whether that's working within those teams and that type of thing, well then that really helps. Being really clear and specific and finding what the hook is. So why is that of interest at the minute to a policymaker? And particularly, especially now, it's really important not to just repeatedly describe the problem just in another way, like offer some solution or offer, if you haven't done those solutions, have a look at NICE or evidence reviews or Cochrane reviews. What else is of value to policymakers that they might not have thought of? So try and do that. And short and concise, like we were saying, really short and concise. That's if it's written. It doesn't always have to be written. It can be, verbs and meetings. The huge topic is a tricky one. I'll have to think about it for a minute. Oh, I lost it to me.
Yeah, maybe I'll tackle the specific one first, and maybe we'll come back along the line. Yeah, I guess. So you're going to remind me what the specific one is. How to write
Well, concrete tips for communicating research and stuff.
Yeah, actually, it's just something that you were saying that prompted me to think. Yeah, it doesn't always have to be written, as you say, and we've started showing slide decks sometimes, which can also be quite useful, I think, and nice to see your charts then getting reused in reports, and that could be useful. Yeah, I'm gonna.
I'm sorry. So coming back to the concrete, so I think health inequalities researchers are really passionate about what they do. They really care about it. It's not a field you go into because you're going to make loads of money. It's not a field that pharmaceutical companies are lining up to pay you to work for them to do. So people who do it often really care about what they do. And so they write quite passionately, and they say things in a way that policymakers sometimes interpret as shrill or hyperbolic, or they policymakers are really boring people. Sorry, if you've ever read policy documents, they can't say they're very risk averse. So you have to say things in a particular way to make sure you're not upsetting anyone. And often you say things in such a way that it doesn't really mean anything anymore, right? But so you've got to find a way, some balance between actually saying something, but saying it in a way that lands well with policymakers. And I think as a community, health inequalities researchers are quite bad at that because we think we've got some kind of moral point to prove, and anybody who doesn't agree with us is evil. Which may be true, but we still have to communicate in a different way to make to be a little bit more pragmatic. And so I think that's a specific thing. I have no idea of the big thing, but
Just one more on the specific then. And this is not from me, this is because I was at an event recently where Chris Whitty was sharing his insights. But I hadn't really heard this before. He said it's really important to put your own work in the context of everything else that's been done, and to be explicit and open about the strength of what you've done, but also the limitations, and not to sort of oversell what you've done. And I thought that was really useful as well.
I thought about one that's kind of more complex. It's not policy per se, but just a live example at the minute is that in Public Health Wales, we've done some work in unprecedented Public Health Observatory, but focused on diabetes and the challenges of increasing prevalence and incidence in diabetes and childhood diabetes and management of long-term complications, and what that means for Wales for the future and the projections. I'm feeding that into the Health Minister in Wales, but actually the solutions sit across primary care, acute care, community, lots of different areas. And that's an example where you can have your data clearly describing the problem, describing what the projections are going to look like for the future, but then actually starting to work through, well, what are some of the different things that different parts of the system might need to do to help to address that? How do they work together? And that has now led to more work and movement in the right direction to change that. So that's kind of one example of a huge complex problem with the solutions and with one part of the system.
Great, thanks very much. Sorry for those unprecedented questions, but actually we welcome more. So if anyone wants to submit anything, or in person or online, then feel free. But really now I'd like to kind of talk about all of your own work in a little bit more specific sense. So I wanted to know if you could share an example from your work where data science research has directly influenced a change in health policy to promote equity, and then what were actually the key success factors in this case?
Do you want to, yeah?
Yeah.
Oh, I muted it. Sorry.
So I think there's kind of different levels of impact that you can have, and maybe it's a little bit too ambitious to think that you change anything on the ground, but maybe somewhere along that kind of pathway, you've made some small changes. So one of the pieces of work I did was to create a set of inequalities indicators for the English NHS. And we did this at CCG level. And so we produced a set of indicators as a research project for looking at how inequalities in various different avoidable conditions vary across CCGs. And we did this with kind of co-produced with the NHS. We had them, NHS England at the time, I guess it's still called that, were quite interested in trying to, so they'd kind of done the Health and Social Care Act, and they said that they had, in that they said that they had a legal obligation to tackle health inequalities, but they had no clue about were there any health inequalities, how big were they, where were they. And so we said, okay, to operationalize that obligation, what about if we start measuring them? And then, so we created this set of measures, which they then adopted, and CCGs all started to create these indicators at their, we created the first set, and they were updating them, and then they were able to compare across different CCGs and try and learn from each other. Now, whether they did or not, whether the CCGs lasted long enough before they were abolished into the next thing, so it made a difference. It's kind of a minor win in terms of like something was adopted by government and looked at for a little while. So, but I think it's hard to follow these things through and really know, did anybody actually not die because of that? Did anybody stop smoking? Did anybody, and so that kind of level of real impact, I don't know if any of my work's ever had.
So I crowdsourced some examples from my colleagues. So this one is actually not specifically my own work, but from the data analytics team. And so we've got something called the Network Data Lab, which you're not familiar with, because she's one of the sites. So there are 5 sites across the UK, and also a Central Health Foundation team. And one of the things they've been looking at recently is children and young people's mental health services. And the example I've got is actually from Leeds rather than Wales, but really that piece of work, the Leeds site have improved their collection and reporting of certain protected characteristics. And so it came about because they set up a finished group, and they had various people, including service users, providers, and commissioners, and they were asked about the findings of the analysis that had been done, and then how were these project findings going to be taken forward. And service users were asking questions specifically about services for young parents and also for members of the LGBTQ+ community. And this revealed that there wasn't enough data. Data quality issues meant that the questions that they were asking couldn't be addressed, and so then there was a separate work stream that was set up about improving the data quality on those things. So it ended up a data scientist was recruited and worked with the mental health providers to look at the problems of data collection and to come up with some solutions. So I think that is a very local example, but quite a nice sort of tangible. I should say it's not necessarily directly feeding into improved health outcomes initially, but it's an example of impact, I think.
Thanks, May. Yeah, we kindly funded by the Health Foundation, and Wales, and actually collaborating with Social Care Wales and DHCW as well too, which is our digital health and care Wales. And one of the examples I was going to draw on actually is we've used some of it to feed into the report that's just out from the Network Data Lab yesterday or today, I think, on unpaid carers. So in Wales, the Welsh Government will have a strategy on how trying to support unpaid carers. But actually before that, we started to look at to what extent you can understand the health needs of unpaid carers in health and care data. And one of the big problems is that they're underrepresented. You don't know who they are in a health care data system. So we worked with the UCL Data Bank and linked the National Survey for Wales with primary care and local authority data, because local authorities are funded to carry out carer assessments to see how they can support their carers. And you can see in rating data, it was tiny, but less than 5%, I think, of unpaid carers in terms of the National Survey for Wales were identified as an unpaid carer in routine health and care data. So, and then we were able to look at actually their underlying health needs, but also then the importance of education and employment whilst caring, and that had a positive effect on the well-being of unpaid carers. So all of that, we work really closely with Carers Trust Wales, so the charity, the fantastic, really interested in the work that we were doing, and then it fed into Welsh Government's work on unpaid carers, and actually started up another discussion about, well, the pros and cons of having an unpaid carers register for people in Wales, and whether that's something that helps or doesn't. And there's lots of different reasons why people don't declare, I don't know if that's the right word, but say that they have caring responsibility. But that's an example where the work that we did then is helping to shape the policy, but actually shape the thinking as well moving forwards. And that's a really nice one with that the team did.
I'm going to jump in with a couple on the slide, and then if anyone in the room has a question, we can start opening up as well. There are a couple of questions, not really related to what we've just been talking about, but around standards and regulation. One on what standards do there need to be around sharing research where other research can't verify the data and methods used, and go on to influence policy. And then the second question on whether you think professionalization standards and regulation will drive data science research to become more.
Ooh, so I'll pass it this way in a minute. The one on kind of open science and transparency. Well, I think there's certainly over the past couple of years, there's been much more emphasis on sharing not the data, because you can't always share the data, but being really clear on the data that was used to inform research, but also the code that was used. So we've been putting stuff up on the Health Foundation GitHub, for example. I'm trying to get our own NHS GitHub. That's really tricky, but that the importance of transparency is really key. But I'm not sure there are official standards. I don't know if anyone else does know that. The second one on standards of practice, I think that is. Well, you heard about the safety framework for data science and equity from the Turing. There are others. There's one that's just actually gone out to review called the HEAL framework that was developed by the Duke Institute over in America, which has a focus on data science and equity, and has a lot of the similarities with the safety. And there's another that was published, I think it was only last week, on Standing Together, which is all about making sure that the data is in good shape, so that the data itself doesn't have an impact then on how equitable the tools are that are generated from the data, and then how we go about the data science and the equity in that. Now, at the minute, none of those are professional standards. They're kind of principles of practice. But whether with the likes of the AI Safety Summit and that emphasis and critique, particularly on AI tools, whether that will move us into a direction where we need better regulation for equity in data science tools, I don't know. Let's shape that for the future.
Yeah, I'm not sure about standards, but something that has come up we were discussing recently in another event was how approvals for drugs and therapeutics require the really careful scrutiny of the data and that you just don't have that at the moment with sort of AI and data-driven technologies that are being incorporated into NHS services. So that definitely feels like a real mismatch, and hopefully something that is going to be addressed, because I think there's just not enough need at the moment to explain where the data's come from and what its potential biases and all of those things are. So it seems imbalanced that having drugs to meet such a high bar, whereas some of these other data-driven technologies don't at the moment.
Yeah, I think it's, so there is, I guess, the kind of whole academic process of peer review, which to some extent is supposed to interrogate the methods, and I think I wouldn't accept any paper that I didn't understand if they weren't able to explain what they've done. Whether I'd be able to replicate that because of access to data, that's a separate question. I think another thing which I guess that's kind of developed in the scientific community is this kind of systematic review and meta-analysis. So just one result doesn't necessarily have to drive policy. I think when you're making policy, you should look across all of the related studies, bring them together, and get a sense of what's the message you're getting from it. So I think there's a big role for systematic review, and maybe that's an area where data science and some automation might be helpful, because it's quite tedious to do these systematic reviews, but actually they're incredibly useful. So if somebody's gone through 1,000 articles and summarized the key point and told you which studies found something slightly different and why that might have been, that's really, really helpful as anybody who wants to interpret that result, for anybody who wants to interpret it. So it's not an exciting piece of work to do yourself. So I think there are some things already that we don't necessarily need to reinvent, and then other things like sharing code is becoming more and more obvious to people that they should be able to share their code. But even, I mean, a lot of you will have seen the kind of controversy in the big behavioral psychology studies where it's clear what they did, it's how they did it, but those results were not replicable, and then actually some of them have been suggested to have been fraudulent. And so that basic ethics, and I think that's maybe where the second part comes in, that professional standards, that kind of having some kind of pride in your work and some credibility and some dignity in how you do your job is also important to inculcate, I guess, in young researchers.
There are a lot of things happening these days, like for instance, AI regulations, climate changes, education, and other things, both within this country and both within healthcare system and other things. And I wonder whether you have any practical tips for us to choose a relevant topic approach or institution to advocate as researchers or as people who might have some collaboration on something with policymakers.
I can go first. I mean, personally, I think climate change is probably the most pressing issue in the world today, and I think thinking about how that relates to everything else is kind of under-researched. Thinking about the links between climate change and health, climate change and transport, climate change, and so really thinking about those things and thinking about solutions rather than just describing the problem, I think would be really valuable. So if I was thinking about doing a PhD now, something in that space would be where I would be looking.
I guess the AI is the tools to answer the question, isn't it? And you know, I think as you've already said, it has to be something you're passionate about, and also something that you know that policymakers are asking them what their priorities are. So I don't think it's really further for me to sort of suggest topics, but I think I would not start from the method, but from research question, which is maybe not helpful.
I would go with what you're interested in terms of the topic, because the tools and the methods that you apply, especially the grounded in maths and the science and the stats, you will find over a career that you can transfer them to different questions. So the most important thing is about picking something that you're interested in, and not worrying too much about it. Things always come back round as well. They really do. It's like different governments, different things, we just keep coming around in circles sometimes.
It's like mullets.
Thanks very much. And so, yeah, I mean, there's a lot I could comment on there. It's been a bit meandering, but you mentioned about the data standards and this kind of thing. I wondered what experience you've had in terms of data privacy as well. So, kind of what ethical considerations should data scientists and policymakers keep in mind, firstly, when working with sensitive health data, which often you may need to answer these kind of important questions, and then how can we actually balance data privacy with the need for these insights to address health inequities?
I'll go really quickly. I think with the data privacy, one of the things that's kind of helped, particularly in Wales, is the work that we do within the UCL data bank. It's a trusted research environment. So whatever we want to do with the data, we have to ask permission through an integrated governance review panel, so an IGRP process, that then asks the data owners, are we using this data in a sensible way? And that's not just health owners, because actually there's policing data in there, local government data, public health data, all sorts of data. And how you're going to use that data. And as you're using it, what you're going to, the principles about, you end up with small numbers and aspects like that. And then whenever it comes to getting more outputs out, the data is all reviewed through a secure gateway. So someone checks it, that there's nothing that's patient identifiable or at risk of being identifiable that gets taken out of that system. And that's really, really important for actually patient and public trust in us, because that's the biggest problem. If we get it wrong, the privacy wrong, well then we'll lose trust. And that then has challenges in terms of how we want to use data. So that trusted research environment is one in Wales, and NHS Scotland has the same system, and then in England there's the start of new secure data environments, which I'm sure will have the same type of approach whenever it comes to it, and that's particularly NHS data.
Yeah, I totally echo that emphasis on trustworthiness, and people, public, might be concerned about how their data are going to be used, aren't they, and who's going to use it. And so we've already said those things about open analytics and sharing your code and making sure the way that you've done things is totally transparent and peer reviewed. And also, I think, again, that patient involvement and engagement and opening yourself up to being challenged by members of the public on each of your projects is just one way of being more out in the open there. I guess the other things maybe as a data science community we should be advocating for ethical use. We have an opportunity to comment on data strategy, health data strategy. There's been several reviews recently where data science community have been able to input, so I guess we can influence at a kind of high level as well.
So I think we've heard a lot about government data or administrative data, and there's a lot of checks and balances to make sure that that's used appropriately and that any risks are outweighed by the benefits of the analysis. I think maybe more interesting is private sector data, so the data that social media organizations have about us, the data that supermarkets have about us, the data, and how is that regulated, if at all? What can they do with that data? What have we clicked to say that they're allowed to do when they inevitably give you, pages of nonsense, and then you just have to say, yes, okay, I just want to see my friend's photograph or whatever it is. So I think that's maybe far more worrying about what can people do with that data, who can do it, what are the ethical implications there. And I think as a data scientist, is probably much more likely to end up working at some kind of one of those places than working on some boring hospital records, or so I think it's maybe a slightly broader question as well, and I suppose maybe some of that AI summit and that world is starting to think about that. How do we use that data? Are we training AI algorithms with that data? Is that fine? Are we discriminate against certain types of people using that data? So yeah, I think there's probably some things to learn from what government data has done, but also I think often we're very, very restricted with government data, and you want to do some analysis and you end up putting in an application, and it might be a year before you get access to your data. And in the meantime, in the wild west of the private sector, they're doing all sorts of nefarious things, which nobody seems to care about. And so just keeping that whole picture in mind is also helpful, I think.
I'm gonna jump in with a question or two. Are there any examples of where public trust has been lost in like the use of their data? I know there was the example during the uproar during COVID around GDPR. Are there any other examples of maybe one you could kind of expand on what happened? Your take on?
Might be interesting to hear if everyone else has got an example.
Yeah, that's I find the term AI, I think goes because I worked with data for a long time, and it seems to hear is something quite monstrous, and so that's one of the important things that those data scientists need to sort of contribute to a more nuanced debate about what kind of technologies that we should be worried about. It's very unspoken systems with big data that are for policy or but it seems to encompass sort of almost anything that has to do with data or statistics or
There's a couple of things that come to mind. So one was there was this plan to make primary care data available for researchers. So I think it was called care.data, maybe 10 years ago, maybe a bit longer. And there was a big campaign to stop that happening. And I don't know what was underlying the particular concern there, but it didn't really happen in the end. And that data kind of exists, but isn't really used for research, and it would be really helpful to have. And some alternatives to that did come about. So I don't know the full story there, but there was definitely something going on there. There's another example I remember of when I first started using hospital data. So there's something called the hospital episode statistics in England, and there was this article in the Daily Mail saying that hospital episode statistics are rubbish because there's a whole number of boys who are pregnant in the hospital data, and that's just stupid. And it turned out it was boys who were being born, and that was a pregnancy episode in the hospital, and boys do get born. So there are these kind of sometimes sensationalist media articles where they haven't really understood or interpreted what's going on, and they can often drive a lack of confidence in some of these data sets, but I don't know how many of those are justified. Yeah.
just while you're going on there, one of the consequences of that care.data and the GP, I can never get the GTPP or whatever, was that there was a big rise in the number of people that opted out of the of letting their data, their GP data be used. So yeah, it's a real concern, isn't it? And I think actually certainly initially it was in the less deprived areas where more people opted out. So although you might have a concern about inequalities, it might not have worked in the usually expected way, but I haven't looked since that. Yeah, those things can exacerbate inequalities potentially as well.
Just as an example, kind of in between the public health and the private college distribution that guaranteed distrust was, at least in my country, in the beginning of COVID, there were a lot of these COVID apps that tried to avoid the way came controversy impact for the and in the beginning it was a big surge about people being really excited about that and being a really big solution. And then immediately that a lot of people saying, oh no, that I don't want the government to know about my immediate whereabouts and where exactly I was and who I got into touch with. And then that sparked a big discussion also about other apps, sharing a little bit, location data and contact data basically. And I think that off the back of that, that charged a little discussion, but I'm sure we're going to get to the Cascading this continues. Yeah, I was just going to follow up on sort of primary care data, I guess. So I work on primary care data, and I think there is a misunderstanding of how to use that data. We're not always very good at getting that message across. I know personally, my GP practice writes to me and advises that I opt out. So it's not just the individual. We need to make sure that the people that are inputting and have ownership of that data understand the research process as well. So my GP practice has decided that whatever the NHS will be doing with that data is going to be dangerous, and they're writing through all of their patients saying opt out because you don't want the data sold. So yeah, I think we've got a public image problem when it comes to using some of that data.
So again, I think there's this kind of interesting distinction between kind of government data and like private sector data. So I don't know if any of you followed the Edward Snowden episode, right? But it was really quite scary how everything on all of our phones is basically tracking us and being used by government to monitor all sorts of things. And the kind of immediate response to that is that, oh, I shouldn't have a phone, I shouldn't have any of these apps. And then, you know, actually I need the phone and then you kind of implicitly give consent to all of that stuff. Whereas with any kind of government record, you can just tick a box and then no one's ever going to use the data again. And it's not like, there's a kind of very asymmetric approach to how we treat, you know, the private sector. We're like, yeah, they shouldn't do it, but they are doing it. Do you want to use their app or not? You know, and it's up to you. Whereas with the GP data, it's like, fill in this form and we'll never use your data again. And we'll never, you know, and it's quite different, and it's quite disabling for researchers to not be able to see that whole picture. And so it's just, I think as a community, it's worth just bringing up that asymmetry and just thinking about how might we tackle that.
There's a couple more questions in the chat. One specifically for Alisha. Alisha, what kind of data do you use in public health and planning equitable distribution of services or resources? What data do you have? What would you like to have?
We use a mix of data that we collect ourselves in the services that we provide. So within public health bills, we have cancer screening services, We run vaccine programs, we run stop smoking services, and all of those. So that's public, that's NHS data survey that we generate and we use. We also use NHS data that comes from other parts of the system. So if you think of cancer again, we'll have cancer diagnosis rates, stage of cancer, all those aspects that are in other parts of the NHS, but that we have access to within kind of the NHS data system. But then within the team, my team, in research and evaluation and other parts of actually public health fields, we use other sorts of data that are either in primary care. The only way that we can get primary care data at the minute in Wales easily is to access it through the SEAL data bank, so through that research data bank that enables us to link anonymously individuals' primary care and secondary care records. And then within that same space, we can use ambulance data, NHS 111 data, it's linked to the census, we can understand people's housing and employment status, all those different things. And what that enables us to do is to look beyond just age and gender. Whenever it comes to describing inequalities, ethnicity is really poorly recorded across NHS and other data sets. So we do what we can with that, but then being able to actually have the census of the spine has enabled us to look at bowel cancer screening uptake and differences by ethnic group during the COVID pandemic, and doing that in that secure data environment. But then there are many other, whenever it comes to equity, you kind of think of those three and deprivation being the other one. But there's lots of other dimensions to equity, and we don't systematically collect that type of information, and we need to get better at having the data systems that do that, but also explaining to the public why we want that information, and then using it. If we have it, we would use it to help to inform campaigns or messaging or where we get services, all those types of things. So hopefully that helps.
A couple of related themes. One is around digital and data literacy. The specific question is around, I guess, digital data literacy of the public, and whether, you know, do we have the fundamentals sorted out. I think this kind of relates to this issue of, you know, people's trust in data, and whether people really understand what happens to their data, both in a public setting and a private setting. Really more of a push in that respect. And a related question around, I'm gonna let you answer this question while I formulate this.
That one's a quick no. I don't think people have any idea what happens to the data. I have no idea what happens to my data. I don't even know where I'm leaving data behind me in a trail. Like, I don't know where it's being collected. Different things, everything you do. But I think people are becoming more aware that they do have data. Adam Stevenson's term, who used to be the Health Foundation, but you call it data shadows. So you're leaving data shadows everywhere. And people are becoming more aware of that. But in terms of literacy about that, I have no idea. My parents have absolutely no idea. My kids might have a bit more of an idea than I do, but I'm not convinced.
I think that's much to answer that. I completely agree. My train of thought, so I'm going to hand over to you while I try and remember what I was going to say.
So I think one of the things that's changed recently is that when we were growing up, we were in a kind of non-digital world where we didn't have this data shadow following us around. Maybe in government records we did, but in everywhere else, there was no internet, there was no, everything we did wasn't tracked. Now people are growing up, you know, my daughter's almost 2 years old and she's already got a footprint on the internet, and she doesn't have much say in that. And as she gets older, she's going to have different opinions about, or different understanding of what that data shadow is, and what the implications of that are. And it seems kind of unfair in a way that she's going to have left this data shadow behind her, which she later realizes she wished she hadn't, in some ways. And so it's just interesting to think about how things have changed since everything has gone digital, and what does that mean in terms of these data shadows and people's consent to provide data at one stage in their life. Should that be binding over their whole lifetime? What about after they die? What about who owns that data? So there's a whole bunch of issues around that, which I guess is still evolving.
I think I'll pass back to that.
Say about the not exactly answering the question, but there's a concern also about the inequalities in who's got data, and then if you're not in the data sets, you're not able to be used for future, in analysis that makes plans for future services and test interventions and all those things. So there's kind of two sides to that. Your data being made available to everybody, but it's systematically certain people are not so well recorded, aren't they? And that's got real impact for us as data scientists.
Okay. Yeah, thanks very much. It's been very insightful, and I'm afraid we're about to run out of time, even though I'm sure there's so much more we could say. So really, I wanted to just ask the panelists to sum up. What is the single actionable step you believe that statistical methods for health equity community should prioritise to help bridge the gap between data science and health policy, or health equity policy?
Yeah, so I think we've said this already, but and I know that she does do this already, but I think one thing that would really valuable is sort of convening events where the data scientists meet the sort of evidence users, and some help with sort of identifying what the research questions are. Yeah, so helping make those links, as we've said, it takes a lot of time, and it takes a lot of, you have to have the right relationships, and that's maybe something that community network can help with, to bring data scientists together with those users of the evidence.
I would, you've heard from examples of kind of principles of data science in terms of the equity that I mentioned. So if it's one concrete thing to take away, I would start to use that type of thinking in what you're doing with the data and the questions that you're asking of the data, because that in essence will help us towards more data science that's addressing health equity and helping in that space as well too.
So I'm going to say something that we haven't really touched on very much, but I think health equity is about fairness and what's fair and what's not fair. And that's not an analytical question. You can't run an algorithm and decide something's fair or not. You need to make some social value judgment to decide that actually this is fair, this difference between these people is fair, and this difference is unfair, and this is how much I care about it, and this is what I might sacrifice in order to reduce that inequality. And so I think keeping in mind that there's a social element and an ethical element here, and not just a computational or algorithmic element is useful and valuable. And I think if you're working in this space, then yes, be very good at your technical skills, but also start to think about those other social issues, the political philosophy, the ethics, and what does fairness mean? Why do we think this is fair? Who has a mandate to decide something is fair or not? Make sure you're not baking value judgments into your analysis, and rather, separate those things out.
Thank you so much. I think those points are really interesting and useful for me, and I hope everybody else. And so I'd like to thank the audience for their wonderful questions and the panel for their fantastic insights on this topic. So if anyone wants to give a round of applause.
We are pretty much at the end of the day. So let me, if you haven't filled in the feedback survey yet, I'm going to ask you to scan this QR code. It will only take a few minutes, but it's very, very helpful for us. Also, apparently it's mandated by the ESRC, so I'll get pulled off if you don't fill it in. So I'm going to just leave that up for now. So we're going to go down in a few minutes, back to that, down to the South Cloisters, where we had the tea and coffee. There should be some drinks available there, and we've got the space until about 6 p.m. So do stick around for some more discussion if you're available. A few announcements. So the recordings for the whole of today will be made available soon. We'll send out an email with the links to those recordings, and we'll put them up on the Data Science for Health Equity website via YouTube. We have Dishi are having an exciting launch event. We've been working on a new strategy over the last few months, which we're happy to launch on the 23rd of November. Will also be a hybrid event, so you can register to sign up in person. Last time we had deep fried ice cream, so if that isn't like exciting enough for you to register, then I don't know what is. Yeah, exactly. So you can register. That's the in-person registration on the QR code just there. We also have very exciting Angela Saini, author of Inferior and Superior, will be joining us in conversation from New York to talk about all things health equity. So last but not least, I would like to say thank you to our hosts and sponsors, AI Fringe, Festival of Social Science, and the Alan Turing Institute. All the photos there, the organisers who made this whole event possible. So Leandra, Awaz, Claire, Sood, who wasn't here today but has been monitoring everything online. So big thanks to Sood, Vanessa and Evan, who's guarding the drinks downstairs at the moment. Thank you to all the speakers for today, and thank you all for attending and being such great audience members. Thank you. Oh, great.